કોમેન્ટમાં લખીને લાવો ને. હા, એ લખી લાવો.
Hello, mic testing 1, 2, 3, 4.
નીચે જ છે ને. હા હેલો.
હેલો.
હા સર, હવે આવે છે અવાજ.
આયો?
હા બરાબર છે. એ તમે છે ને એક જ ફોનમાં લોગિન ને એવું હશો એટલા માટે.
Okay. Now,
હા.
am I audible?
યસ યસ.
So I am going to start something. My photo is not visible.
કેમેરા ઓન કરવો પડશે તમારે.
તો મેં એમ ઓન કર્યો હમણાં, પણ એમાં આવે છે you cannot start your video because the host has disabled it.
હા હા ઉભા રહીજો 2 મિનિટ.
Yes. I think so. Am I audible to everybody? And welcome to today's surgical academic feast. And today's this is our launching of surgical, where we are launching a redo surgery. Especially our interest is redo surgery. As such, we are in IVF, we are always interested in recurrent IVF failure. So we are thinking about that. We are not interested in a simple TLH and all this thing. We are interested where there is redo surgery, maybe deep infiltrating endometriosis, maybe when there is a frozen pelvis, maybe something about that there is a Asherman syndrome in the hysteroscopy. Maybe we are interested in all the onco surgery, especially when it is operable by laparoscopy, and where we have a very eminent faculty who is joined WINGS, and who everybody knows the upcoming, and I think so very good surgeon, Dr. Divyesh Panchal. You know the experience of Dr. Divyesh Panchal has experience in around 12 to 14 years in GCRS, Gujarat Cancer Research Hospital, and he is having a 2 years fellowship in the Tata Memorial Hospital. He is having a lot of surgeries which he showed on the lot of this type of live surgical workshop. And I think so now people are knowing him as a difficult, when there is a difficulty, when there is an unoperability, he is one of the surgeon who goes beyond the retroperitoneal structure where the scale is required. And I think so he is a master to go where we all are gynec people are worried about to go in the lateral pelvic dissections to separate the ureters and everything. He is also having a very good team with the surgeon, and I always appreciate Dr. Divyesh Panchal that there are certain things where team is required. It's not like that, and if somebody's comment like that, why? It is not like that. Everybody, if you ask me, the leading surgeons, the leading gynec onco surgeons or something, they have a team. So this is the team where the two people together, where they can work together. If something is required on the part of intestine or something rectum, these are the surgeries where he can also with the help of the surgeon, onco surgeon, whenever it is required. So I am saying about the gastro surgeon, where they can help of the gastro onco surgeons, or they can have a uro onco surgeon when they can also have some onco surgery. So these are the team which is with Dr. Divyesh Panchal, and he's creating his own way to go ahead. What he wants to say, the clear cut message that in surgery, I will always like to say, in our medical professions always, that show your skill. Then I think so it is always available on the screen, and everybody will always accept the skill, and then yes, we will respect the skill. And we know a lot of people, those who are having a lot of skill, and they are still praised in when they are clapped when they are doing their surgery on the screen. So today's we are having launching our redo surgery and gynec onco surgery department. And I think so everybody is ready. We are slightly late, 30-minute late. Sorry for that late, because of the communications and all audio, video, visual communications, certain things which is never in a doctor's hand. But I think so within a few minutes and seconds, we are going to start the surgical. And surgery, live surgery, I think so.
Yes, sir.
Yes.
Absolutely right, sir. And there is a delay due to the patient preparation and lack in the coordination. But now we will start within 15 minutes. Myself, Dr. Divyesh Panchal, and let me know all about the case. Today's case basically is a 57-year-old female with ASA grade 2 and ECOG 1. She has a chief complaint of postmenopausal bleeding since 2 months with on and off spotting per vaginally, and she is a known case of hypertension and diabetes. So with comorbidity, she has been evaluated with endometrial carcinoma, that is grade 2, type 1 endometrioid adenocarcinoma, that is type 1 and grade 2. Her BMI is 30, so patient is obese, overweight. Clinical detail, we have done routine investigation. CA125 is normal. Her HRCT is absolutely normal, and MRI pelvis and abdomen, same findings we can see. Uterus is mildly bulky. Invasion of the myometrium, that is more than 50%. So it is categorized under stage 1B, and it is of type 1 endometrial carcinoma, that is endometrioid type, and grade 2 moderately differentiated carcinoma. No evidence of any extension or to the cervix. So pervaginally there is no parametrial invasion, no cervical involvement, and MRI suggestive of elongated lymph node along the common iliac internal bilateral internal iliac region. Right side, that is 1.3 centimeter, and left side, that is 9 by 5 centimeters. So plan of our surgery today is basically laparoscopic hysterectomy, that is extrafacial hysterectomy due to endometrioid carcinoma, because it is it falls into the intermediate risk endometrioid type 1 carcinoma. So we will go for TLH bilateral salpingo-oophorectomy with pelvic lymph node dissection. We will send. Today we have no in our routine we are not performing sentinel node biopsy. So many studies are showing sentinel node biopsy significance, such as in ESCO update, SHREC study, and FIRES trial suggestive of good negative predictive value and good sensitivity about the sentinel node biopsy. But we have no facility of sentinel node biopsy. So it is grade 2 and involving more than 50% of the myometria. We will send the uterus and the pelvic lymph node for the frozen section. If any lymph node that is suggestive of metastasis or positive turn out, then we will go for systematic retroperitoneal node dissection. So we have with us today my teacher and mentor, Dr. Anjana Madam. She is very renowned consultant gynae oncologist in Ahmedabad. So I welcome Madam. Anjana Madam, please.
Hello.
Welcome, madam.
Welcome, Dr. JS. It is very nice and grateful to be the part of this workshop and to watch Dr. Divyesh doing a radical surgery for CA body, and it's honored to be a moderation for this session. And I thank the WINGS committee and Dr. Jayasamin specially to give me this honor. And it will be a pleasure to see live laparoscopy workshop, laparoscopy of carcinoma body, which he is going to operate. It's a very obese patient, diabetic. I think that this is an ideal case we should do. And the minimal invasive, it's good for the patient, and the outcomes are similar. So it will be a pleasure to watch. I think so we should start our session now. Yes.
Patient is already induced and
I just want to ask what Divyesh, what he is planning, what is the history of the patient?
Madam, I have already mentioned because it is stage 1B, and that is 50% myometrial invasion and moderately grade 2. So we will first do the simple extrafacial hysterectomy as usual with bilateral salpingo-oophorectomy with pelvic lymph node dissection, and we are planning to send lymph node for the frozen section. If any of the lymph node turn out to be positive, then we will go for systematic para-aortic lymph node dissection. But imaging has shown there is no enlarged lymph node along the para-aortic region or below the infrarenal or anyone, and we have already performed tumor board with our onco-radiologist and oncopathologist for this, madam. So there is importance of sentinel node biopsy, but we have no facility at present.
That facility is not available in India, so probably what you are doing is absolutely right. I think so if we omit para-aortic in this particular patient, I think so it will be sufficient because it's less than 50% parametrial invasion. So, okay, sure. I think now we are starting the session.
अंजुबेन आई है. I welcome all the dignitaries, all the moderators, Dr. Pooja Patel and everybody, those who are on the board. And let us welcome also the other doctors, other delegates, those who are going to see the surgery. I just must say to Dr. Divyesh that always surgery is always surgery. So our all best luck to do a maximum performance in this surgery, to do maximum to the patients. Dr. Divyesh, you are not audible. Dr. Divyesh.
Hello.
Yes, now it is audible.
Okay, okay, yes, sir. So we have introduced our first trocar, that is 10 mm. Start the CO2, please. कैमरा ने रेडी करो चाल से कवर नहीं कही जरूर हाँ Okay. Hello. Am I audible? Hello. So
You are audible. You are audible.
yes, sir. So first step, we have already examined the whole abdominal cavity in clockwise manner. Seeing there is no any deposit or anything that is suspicious about malignancy. So in our surgery, our first step today, always starting from sigmoid mobilization. So I am mobilizing the sigmoid colon, and I will 2 minute. Yeah, bus 2 minute. Over slowly. 2 minute. So now trial has come about can we use manipulator or not. So in case of endometrial carcinoma, we can manipulate with the blunt tip manipulator, but I am trying to finish the hysterectomy without manipulator. We can see here is lateral umbilical fold. So I will cut our round ligament as lateral as possible to gain access to the lateral spaces. So first is round ligament. मैंने IPL पकड़ी. Okay. Okay. So you can see I can with the left hand I can give traction to the uterus towards my side. Okay. So first step is to dissect parallel to the infundibulopelvic ligament. So our today's associates for this great webinar are, first of all, I would like to thank COVIDian people. So they are with us. Jay sir, they are with us from yesterday. Second, Lotus, they have provided us nice visible port and camera system. Of course, no one can match with the camera system of stores. So I am very much thankful to the stores people. They are very busy in very much promotion and conferencing, but they have given us time today for this webinar and providing the system. So I will first coagulate both the fallopian tube to prevent dissemination of the any malignant or cells. Okay. ઊંચકી લો શર્મા સર, તમે ખાલી મને બસ એ સાઈડ જ બતાવજો. આ પકડી લો ને, ઊંચું કરો. યુરેટ્રિક મોબિલાઇઝ ના ના એ બાજુ નહીં. ઓકે, પરફેક્ટ. યુરેટર આ સાઈડ થી. So I will try to skeletonize the infundibulopelvic ligament. You can see here is the psoas muscle. હેડલો થશે ના વાંધો નહીં આવે ચાલી જશે બસ એ so as lateral as possible and parallel to the infundibulopelvic ligament. Anatomy won't change here. Ureter always crosses on the right side over the external iliac vessels, and it is always medial to the infundibulopelvic ligament. So here is the common iliac artery that bifurcates it into the external iliac artery. So here is our gynecologist friend, that is ureter. Wait a minute. So I am trying as much as to hemostasis to maintain the hemostasis, because any amount of oozing that will create difficulty for us to go or to open the spaces. So this is external iliac artery, this is our ureter. We will take care about this loose fibrofatty tissue. Okay, wait a minute. Perfect. So first goal here is to open the avascular spaces. Here you can see that is obliterated umbilical artery, continuation of the hypogastric artery. So this is lateral paravesical space bounded medially by the obliterated umbilical artery, laterally by the external iliac vessels, and from here we can go up to the levator ani. So this is levator ani muscle. You can all notice, okay? And on the lateral side, there are obturator nerve and obturator vessels. So this is levator ani. Back. Okay. Now we will create space, that is medial paravesical space. આ બાજુ બતાવજો મેન છે નહીં એમ તો કશું. Okay, so medial paravesical space અહીંયા પકડજો ને સર આ ઉપરની બાજુ ઉપર ઊંચું કરીએ, પેરિટોનિયલ ફોલ્ડ પકડી લો. નજીક નજીક જવું. કેમેરો મારી બાજુ, આ બાજુ કોડ મારી સાઈડ. યસ. So this is medial paravesical space which is medially bounded by the bladder wall. Here you can see the bladder wall. Okay, so these are the two spaces that we are first creating and preparing the field for the pelvic lymph node dissection. Okay, back. આ બાજુ અહીંયા પાછળ. Other two species are pararectal space. 2 મિનિટ બેક. આને છોડી દઉં છું. હું પકડી લઉં સર. હા ઓકે. હા કર દો ક્લીન. માસ્ક का સીધું કરો બસ. પરફેક્ટ. સિગ્મોઇડ થોડુંક નડી રહ્યું છે હે ને. So here you can found this is internal iliac artery. So we'll maintain the hemostasis. Okay. External, sorry, this is external iliac artery, my mistake. હજી આગળ આવશે. બેક બેક આવતા બસ ઉપરથી બતાવો. હા અહીંયા અહીંયા ધરો. ઓકે. Okay, so taking help of the obliterated umbilical artery, I am searching for the uterine artery. You can see now beautiful uterine artery here. So dissection is always should parallel to the vital structure. ઉભો રહેજો બસ બહુ હલતા નહીં. ઓકે. યુટ્રાઇન બે મને આપી દો ને યુટ્રસ. ના પહેલા હિસ્ટેક્ટોમી કરી દઈએ. ઓકે હા બસ બસ આ સ્પેસ છે સ્ટેડી. હા હા બસ એ બતાવો ને. હા મૂકો ને. હા ડિસેક્શન થાય ને યુરેટર ને એની વચ્ચે. ઓકે સો here is the space lateral pararectal space. બે મિનિટ આવતા રહો. પરફેક્ટ. એ નોડલ છે એ બાજુ નોડલ ટિશ્યુ. ઉભો રહેજો બે મિનિટ. ઓકે. So as far as this is superior vesical artery here बताओ. So this is the division. We can see this is superior vesical artery. It's the division, anterior division, one of the branch of the anterior division of the internal iliac artery. So this is internal iliac artery, Sharma sir, and this is external iliac artery. Yes, and this bifurcates Here is the common above upper the side batao એટલે દેખાય. Yes, common iliac artery. So it bifurcates into the external iliac artery and internal iliac artery, and this is the first branch that divides this space. That is that divides medial paravesical space from the pararectal space, and the structure is uterine artery. So here is the uterine artery. આને ઊંચું કરો સર.
Divya is very nice, huh? Dissection. It's excellent.
Thank you, madam.
I'm just here, but I'm enjoying your surgery. It's very nice dissection.
નજીક જાઓ.
In such a obese patient to have such a nice anatomy.
Yes, madam.
It's
That
very
is
difficult. It's very difficult.
Thank you, madam. So I will coagulate the uterine at origin. The role of the MIS is controversial when
No,
the
it's
paper.
not controversial
Yeah,
in CA body.
No, CA body, madam, but when paper comes about the cervical carcinoma LSCC trial, then
It is not controversial. It is the
Yes,
treatment for
yes.
CA body. But
Yes,
for
it is
CA
the only.
cervix,
Yes,
for,
yes,
for
madam,
CA cervix, it is a controversial.
yeah, madam.
But
Outside
for
after
CA
the
body,
outside
the
form.
MIS for such type of patient is the treatment.
Yes, madam, definitely. The only role of the MIS in now gynec oncology, that is only the endometrial carcinoma, and the advancement of the sentinel node biopsy has gained now assessed to decrease the morbidity related to the systematic lymphadenectomy and all, madam.
Divyesh,
Yes,
I am
yes, sir.
Dr. Girish.
Yes, sir. Yes, sir.
I am a man of fetal medicine, but I would like to ask a basic question.
Yes, yes, sir. Definitely.
Which are the avascular spaces around the uterus which has been specially made by nature only for laparoscopic surgeons?
So,
Am I
sir,
right or wrong?
no, definitely correct, sir. We have already dissected 4 spaces. That is medial paravesical space on the right side, and lateral paravesical, 2 pararectal spaces, and 1 is vesico, same on the left side, and 2 spaces, that is vesico uterine space and recto-uterine space, that is pouch of Douglas, sir.
Rectovaginal space.
Yes, yes, rectovaginal space. So now skeletonizing the.
There is adhesions of the sigmoid
Yes,
to the
is
tubo-ovarian ligament.
physiological adhesion, but we have to remove these adhesions so we can gain access to and increase the mobility of the bowel inside the abdomen.
It is actually the
Physiological.
norm of the oncology surgery that you should at least have 2 centimeter tubo-ovarian ligament.
Yeah, madam.
So you are doing that dissection, and it's very nicely done. And doing this dissection, one has to be careful because the ureter is very close to the
Close to,
tubo-ovarian
yes.
ligament. So what you are doing is separating the
Batao.
tubo-ovarian ligament
Bas,
and
yeah.
the ureter.
Yes, madam.
Wonderful
So,
dissection.
Yeah, madam. Thank you, madam. So the basic principle same on the left side of mine.
You can show the ligament on the ovary. You can show at least you have dissected more than 2 centimeter.
Pardon, madam.
You have dissected more than 2 centimeter from the ovary. You can show the whole ligament.
Yes, madam. Yes. So batao, ovary batao.
Ovary. See
So
the
this is the round ligament.
Yes.
This is ovary,
Yeah.
and this is infundibulopelvic
Pelvic
ligament.
around 2 centimeter. You
Yes,
have
yes,
dissected.
madam.
Yes.
So
And that is the peritoneal flap where you find the ureter.
yes, madam. So you can see very clearly this is obliterated umbilical artery.
Yes.
Once I found obliterated umbilical artery, then I will go easily to the paravesical space. પકડી લો સર, પેલું.
In the laparoscopy, one thing is very good that the what we can say the
Yes, madam. Assistance require actually teamwork,
yes.
but CO2 can help
Yes.
us very much in
CO2
laparoscopy.
can help to create spaces very clearly.
Yes, madam. It's very difficult to create spaces while performing open surgery. But madam, you are master and you have done so many surgeries,
Uh,
onco surgeries, madam,
Yes.
advanced ovarian surgeries and everything. But madam, now in open surgery, ligature and advancement of the energy sources, we can do more advanced surgery, I
Yes,
guess.
yes, definitely. That's a charm of oncology surgery, that mostly in gynec onco, the disease doesn't go in the retroperitoneal spaces.
Yes, madam.
So
yeah.
that is, if you go to a retroperitoneal approach, opening the spaces, your surgery becomes very good,
Very good.
neat and clean, and no less chances of bleeding and injury to the structures.
So this is medial paravesical space. I can perform hysterectomy earlier, but creating space will save my time in later part of the surgery in lymphadenectomy part. That's why I am creating the spaces,
You are
madam.
doing this space. Yeah,
Yes, madam.
sure.
So this is medial paravesical space, and here is the. We can go up to the levator ani by dissecting here. बताओ अंदर जी. Okay, slowly. So this is levator ani muscle.
Yes.
Okay, back. बस आ साइड હવે આ બાજુ ureter. આ પકડી લેજો સર બસ. પરફેક્ટ. ઉપરની બાજુ રાખો. હા, હું આ sigmoid ને સેપરેટ કરી દઉં. So sigmoid mobilization is the key step, and it will help in the also in the later part of the surgery to perform lymphadenectomy and
Good node clearance.
yes, madam, good
Yes.
node clearance. And the common lymphatics in sentinel node biopsy, I have seen the main affected node is mainly the uh, common iliac at the level of common iliac vessels. Para-aortic, if and in type 1 endometrial CA, suppose the negative pelvic lymph nodes are negative, then the chance of isolated para-aortic node is very less, I guess, madam.
Yes,
What is
yes.
your opinion, madam?
Yes, definitely. The para-aortic node dissection, ideally in
Helpful.
early stage,
Yes.
stage 1B, the node para-aortic is very less. It is around 0.04%.
4%, yes, madam.
So to go for an aggressive therapy for obese patient, we can definitely take a chance.
So as far as oncological aspect, we have to consider also the quality of life. That is the one question that we have to think about, madam.
Yes, and
Not the surgery only.
Para-aortic node dissection has its own complications.
Yes, definitely,
And
madam.
that is the reasons why the sentinel node biopsy has come into the picture.
Yes, yes,
Because to
definitely.
avoid complications relating to node dissection, if you do a good node dissection, that 20-30% chance that she is going to have later on complications related to the node dissections.
Yes, madam.
And they are very bad, and there is it has no treatment. per se.
Yeah, madam. And surgical complication is also there. Suppose there is vascular injury in everything, then it is
It leads
very
to more
difficult to tackle. So here we can find our uterine artery. Wait a minute. હા શર્મા સર હવે અહીંયા મૂકજો ના ureter ને લઈ લેજો. So for general gynecologist, where we can find our uterine artery, so there is a one tip. You have to stretch the obliterated umbilical artery, and you can see the traction. So here, always at the level of angulation, you can find uterine artery here. This is the easiest way to find uterine artery, and it is also helpful in case of suppose postpartum hemorrhage and everything, madam. Here. So these are the space that are the avascular spaces.
The ureter going below the uterine artery,
Yeah,
water
yeah.
under the bridge.
Water is always under the bridge. And here you can found, here is our uterine artery.
Internal iliac.
Yes, internal iliac artery. So you can found so for PPH, we have to ligate internal iliac artery sometimes in case of placenta accreta and increta. So we can get a very good length here to ligate this internal iliac artery above the when uterine artery is originate, we have to ligate the internal iliac artery just above that, 2 or 3 centimeter above the origin of the uterine artery. So that is for general gynecs.
Divesh, this is Dr. Bhavana Parikh.
Madam, welcome, madam. Good afternoon.
Good afternoon, Divesh. You are doing an excellent job. You already have dissected anterior division of internal iliac artery.
Yeah, madam.
You had gone beyond the umbilical artery, obturator artery.
Yeah.
And now you are about to, I think, ligate the uterine artery.
Yes,
madam.
madam.
Anterior division of internal iliac artery. Posterior division, we don't go there.
Yeah.
And there are a few points that you were already discussing with Anjuban that regarding the laparoscopic surgery versus open. It is a very well proved early uterine cancer, the laparoscopy or robotic surgery is standard of care, except for the CA cervix. CA cervix is biggest.
Yeah, definitely. CA cervix now, yes, madam. In CA cervix, I think if lesion is less than 2 centimeter, then we can still perform minimal invasive surgery for that. But I think
for CA cervix, for CA cervix, according to me, it is not a less than 2 centimeters.
Accepted.
Basically, it is a squamous cell histology.
Yeah,
which
yeah.
actually exfoliate and it rupture into the peritoneal cavity, and then it because of CO2 pressure they'll attached to the peritoneal wall or other areas. But adenocarcinoma is basically a submucosal histology, so chances of spillage is less. So if somebody wants to do a CA cervix minimally invasive surgery, then vaginal cuff ligation first method is people now have adopted, but still we are not
it
doing
is debatable. It is debatable, and we should not. Yes, we should not perform minimal invasive surgery for CA cervix. Absolutely not, madam.
Yeah, it is a debatable between one of the US based consultant and versus one German consultant.
Yeah, yeah. It is a trial that is known as leg trial. That is a trial for the locally advanced cervical carcinoma. That is from MD Anderson Center, I think, Professor Ramirez.
Yeah, Professor Ramirez, he already pointed out not to perform minimal invasive surgery for squamous cell carcinoma, preferably squamous, for CA cervix. And another general German consultant who is a gynec oncologist, he's been doing first doing a vaginal cuff suturing and followed by this minimal invasive surgery. So both is debatable. Still date we are not saying CA cervix patient to go for the minimal invasive
surgery, definitely.
But CA endometrium, it is a standard of care. And regarding the uterine manipulator, there is also debate.
Yes.
Yeah, uterine manipulator is one of the most wonderful things. It is one of the most wonderful things.
Still now, madam, in this dissection, we have not used uterine manipulator. Yeah. Also in the endometrium CA, we have not inserted uterine manipulator till now. We are using myoma screw.
You're not doing anything, and still you're performing a very good surgery. Yeah. But in the uterine manipulator, basically, actually, it prevents ureteric injury because it keeps the uterus away from the ureters, and there is a minimal amount of bladder injury if you use a uterine manipulator. But uterine manipulation can give rise to the balloon and the pressure. It actually compresses over the uterine wall, and the
Najik
tumor
jao.
cells, there is spillage of a tumor cells into the peritoneal cavity. That has been found in many of the trials where the peritoneal washing has been taken for the malignant cells, and those malignant cells showing disease,
Najik jao.
that peritoneal washings are showing disease. So uterine manipulation is one of the most controversial thing. There's a lot of debate about the cost of uterine manipulation. There are a lot of companies available for the uterine manipulators, but it is a good thing for the benign pathology, but same time the chances of the recurrence or spillage is more with the uterine manipulators.
Yeah.
And vaginal flap relapse is more with the uterine manipulators. That is what the study shows. Many of the studies show. So
Yes,
that is
madam.
again a debatable topic whether to use a uterine manipulator or not. If you are not using, that is a wonderful thing you are doing, and you are, I think, done a dissection of the bilateral para-vesical spaces, isn't it? Am I right?
Yes, yes, madam. On both sides, we have dissected both paravesical spaces, and now
Yes,
I
yes.
am going to dissect vesico-uterine space. That is the space between bladder and the uterus. ऊंचू कर दो सर मास. So we नहीं 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 आने 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 पकड़ी ऊपर इस साइड. Yes, perfect. नजीक जाओ. So up till now, there is a very much no blood loss at all. And it is also due to the great anesthesia given by Dr. Mahesh sir here. Mahesh Patel sir is our anesthetist, and Dr. Pinal Soni accompanying him for this great webinar. Okay, 2 minute મને આપ પકડી લો. So I think sorry, ઉભો રહે. આપજો મને. હા. Okay. જાઓ નજીક. So now I will skeletonize the uterine artery and comfortably આને ઊંચું કરો શર્મા સર. You will fold. Yes, perfect. So in assistant today I have my friend, that is my very dear friend, and I have learned so many things from him. That is Dr. Vidyasagar Sharma. He's a great surgeon and he's doing so much gastro work in our institute. Just such as Madam Vifal surgery and everything. I have assisted him so many GI surgeries also. And Bhavna Madam is my first. I have assisted my first onco surgery to Bhavna Madam, I think. Madam.
Thank you, Subiyesh bhai.
So it's a beautiful dissection of vesico-uterine space. So, Madam, can I ask one question? What is the role of suggesting like type B radical hysterectomy and everything in case of endometrium CA? Anjana, Madam, is there any role of radicality if there is no involvement of cervix in case of endometrium CA to perform radical
Now
hysterectomy?
the new guidelines are there. The type 2 hysterectomy should not be done. It is removed.
Yes,
Even
madam.
if the
So,
cervix is involved, the stroma is involved, it should be type 1.
yeah.
That is, you do of extrafacial hysterectomy. There
Yes,
is no extra benefit doing a radical hysterectomy.
So why it is extrafacial that I showing? This is the extrafascia, madam, above the cervix. So it should, in benign surgery we are cutting this fascia, but in onco surgery we are preserving this fascia.
Because it is a more a systemic disease. So
Yes, yes, madam.
no need to do a radical hysterectomy. Even in type stage 2 CA body uterus, you have to go for that is a routine hysterectomy followed by node dissection.
Yes, madam. Suppose suppose there is a cervical involvement, then and then only we can think about.
No need to do a radical, even in cervical
Oh,
environment.
okay, madam.
This is a new concept because it doesn't improve or doesn't change the prognosis. So you should go for routine, that is
Routine
total abdominal
hysterectomy.
hysterectomy
Okay, with lymph node dissection.
with
madam.
lymph node. Main is you should concentrate doing a lymph node dissection in those cases where cervix is involved.
Okay.
And probably looking into the invasion, you should go for radical node dissection with para-aortic node dissection, but no need to go for radical hysterectomy.
Okay, madam. So that is the message to our gynec friends, madam. Definitely.
CA body is one of very controversial in management. All over the world, there is no definite way of managing. People manage according to their institute,
Oh, yes, madam. And
according to their own protocols, because there is no fixed guidelines.
guidelines, definitely.
In US and countries where they have a very good sentinel node, because sentinel node should not be a dye, it should be a fluorescent and having a camera, and that is the way you do a sentinel node biopsy.
Yes,
So
madam.
not routine that injecting a dye and looking into the routine. You should have a proper setup and you should have the typical, what we can say, infrared camera doing a sentinel node.
And I think we have to consider risk versus always benefit ratio in oncology.
In India, we don't have that setup
Yes,
anywhere. Only
exactly.
I think so 2-3 Tata is having and Somsekhar is having.
Somsekhar, sir, yes, sir, yes, yes,
So
madam.
probably what we should do, we should follow what routine we are doing.
Yeah, and strictly adhere to the protocol of the oncology.
This is still a controversy to doing a total lymphadenectomy or doing
Versus
a selective.
systematic, yes, absolutely, madam.
And the fact is in
Atraumatic
a
upon
CA
atraumatic
body,
grasp.
what it is, we are doing lymph node, that is most is
atraumatic one. Okay. So is there any question from the audience, madam? No question. ओके पीनट आप जो पीनट बनाई दी नाखी दिए गॉस हाँ बस आप ही हाँ 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 हमारा थर्सडे पर
Divish?
Yes, madam.
Yeah, just this is a theoretical discussion. As I'm also not doing sentinel
Minimal
node
in
biopsy.
yeah, madam.
Yeah, but if you really want to discuss it, then sentinel node biopsy, one of the most important indication is low to intermediate risk patients.
Yeah.
And it is basically a primary lymphatic pathway, which shows actually the mapping process. And if you see the largest randomized control trial, with that is a FIRES trial, it shows less than 5% of the false negative rate.
Yes.
And,
Yes, madam. All I think in ESCO meeting there are 2 trials. That is a Centaur trial, and one trial is SHREK trial. That is by the Swedish people, and they show the high sensitivity and high negative predictive value. I think in about, but still the randomization in the study, I think it is debatable. I think the data it shows the high sensitivity and high negative predictive value, madam.
They've reached to the less than 5% of the false negative rate in a largest multinational. And uterine carcinoma or uterine sarcoma is the only contraindication for sentinel node. And unfortunately, they cannot see ITC. It has not been much studied as it has been studied till date in breast cancer, that isolated tumor cells. And patients with isolated tumor cells has got a better survival rate as compared to those who have got a sentinel node macrometastasis. So if you get a chance and if you get a good setup in early cancer, low to intermediate risk factor patients can be offered, unless we are all trained for the sentinel node biopsy. Either you use a blue dye or either you use a indocyanine green.
I think ICG is good than blue dye, madam.
ICD is absolutely wonderful, but
Yeah.
that requires proper, full setup to use ICG. Even not only it shows the sentinel node, but ureters and all the important structures are also very well seen with the ICG.
શું કહો છો? ચાલી જશે. Okay, so now we will take the uterine artery. We have already ligated it at the origin. સીધું કરો, બતાવો સરખું સરખું હાથ ઊંચો. હા, ઇન્સ્ટ્રુમેન્ટ નડી રહ્યું. ઓકે, હા, મારું પેલું એ છે ને. ઓકે, નો પ્રોબ્લેમ. હા, યસ. So this is the basic hysterectomy. After cutting the uterine artery, we have to remain parallel to the cervix. So we can avoid injury to the ureter. Okay, 2 મિનિટ પાછા જાઓ, બેક. ઓકે, બસ અહીંયા યુટ્રોસેક્રલ જાઓ નજીક.
Actually, this is actually the step where the uterine manipulator can do a wonderful job.
Yeah, madam. But if your left hand is strong, and then there is no need of uterine manipulator, I guess.
Yes.
And we can also avoid many oncological controversy pertaining to the uterine manipulator, especially at this webinar level, I guess. Back. Sometimes it's difficult to deliver the uterus when it's ma'am, in which cases, Anjana madam, you avoid the minimal invasive surgery, especially in case of pertaining to the endometrial cancer. I have performed I think 50 surgeries at our center, that is Gujarat Cancer Society Hospital. But then the transverse diameter of the fundus, if it is more, then it's very difficult to deliver the uterus from the vagina. So is this a indication to
Uterine size, it is not mentioned anywhere. But
Okay,
it
madam.
is said extrauterine disease,
No,
full
it-
thickness disease.
it's technical difficulty that I have
When
faced?
it is a
so
full
I-
thickness disease, na, the uterus is very soft.
Yeah,
And
madam.
uterus size, as you say, it's more than 10 centimeter. It is better to go
Okay,
for
fine.
open surgery.
Yeah,
And
madam.
basically, when obesity is there, I think so. It is if it is a stage 1 or 1B stage, then a laparoscopy, I think minimal invasive is much better.
Sure. Yes, madam.
Full thickness disease, extrauterine disease, definitely you should go for open surgery.
Okay, na
I
bladder.
think so. If the uterine size is more, I don't know, but you can do a minimal invasive and put a small incision on the fenstial and you can
Mini
remove
lap,
it.
yes, mini
like
lap,
mini
madam.
lap. You can do
Yes.
that way. This is an obese patient.
Definitely, madam. Okay. મને પકડી લ્યા 2 મિનિટ. So yes, જાઓ અંદર. So uterine has already been covered. Najik jao.
What is the energy source you are using?
Madam, it is advanced bipolar, that is LigaSure,
Mm-hmm.
and it's very good and the safety quotient with this LigaSure, that is bipolar, is also very good, and it saves our time a lot and also decrease the tension of surgery in case of blood loss and everything.
So it coagulates and cuts.
Yes, madam. So
All
it's
this
very
used to-
good. Yeah, it's a very good tool to go for pelvic lymph node dissection, because with harmonic, I always fear about the active blade over the vessel. So I always prefer this LigaSure for lymphadenectomy, madam, always, or simple bipolar.
These energy sources are made in minimal invasive surgery,
Definitely, absolutely, madam. Very easy, and good.
but you should know how to use it.
Yeah,
Actually, that
basics.
is a luxury into robotic surgery, that you have a both hand having energy devices. At one hand you
Yes.
have got harmonic, and another hand you have bipolar cord.
But madam, pertaining to the robotic, we have not luxury of that is ultrasonic energy and also the
Yes,
LigaSure, madam. Yeah, that is lacking. I think it's a method of research in the next coming days. So how we can introduce LigaSure and harmonic ultrasonic energy in the robotic?
There is one question, Divyesh.
Yeah, madam.
In comparison to open surgery, endoscopic approach is how much in vogue?
How much in?
Vogue, Dr. Girish.
Endoscopy is always better, madam. Actually, considering myself as a minimal invasive surgeon, then I definitely seconded or propose endoscopic surgery for the endometrial CA patient, madam. Definitely, yes. There is a role. But then regarding the various trials and the protocol for the CA cervix, I will definitely not perform minimal invasive surgery in case of CA cervix, or in case of suspicious ovarian mass. Definitely, I will open.
There is no role of laparoscopy in ovarian cancer.
Definitely, except to check the for the operability. I guess there is a role.
No, it has a different, we will not discuss, we'll keep a webinar on that.
Yeah.
Doing
madam,
a laparoscopy in ovarian cancer, it is a different subject and it has different indication.
Yes, madam, definitely. કટ કર દો શર્મા ના હુક અહીંયાથી નીકળી જશે બતાવો ને યુટ્રોસેક્રલ બતાવો હા નીચે આવી જાઓ હા નીચે આવો ઊંચા થઈ જાઓ હા બેક so the great camera work here, I think
That's the benefit in robotics. The
yes,
camera and everything is, you have forearm in your under your control. In robotics, all the forearm is under two active and two non-active.
And
So
robotic is also, but after minimal invasive surgery, you want to become robotic surgeon, then you have to unlearn the minimal invasive surgery first, then you can perform.
Both are a different dynamics. Both are different dynamics to operate. Though it looks vision, it looks same, but the dynamics is different in both the thing.
I think vision is good. That is binocular 3D vision. That is the great thing with the robotic.
But main people who are doing laparoscopy, they find little bit difficult because there is no touch. You have a tactile touch in laparoscopy, but in robotic, you don't have the touch sensation. So whatever you're doing, you don't have any touch. It is just you're doing a surgery in a thin air.
Yes, madam.
So that is the.
આને પકડી લો શર્મા સર, તો મને આને હા અને લીવર આગળ જવા દો. યસ, આવો નીચે હવે આવો. બસ પરફેક્ટ. સ્લોલી. So here manipulator will help definitely. Bhavana madam.
Yes, yes, Divesh. Actually, the easiest way to identify the ureter is at the symphysis pubis, where actually it enters into the pelvic cavity. And this is area where it is, and this area is one of the most dangerous area, or it is the area where the ureter can be easily injured.
ફાઇબ્રોઇડ હોય ને એવું લાગે છે સર્વિક્સ. હા બસ હવે 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 આવી ગયો. So now this is the vagina. I can easily identify and differentiate it from the, yes. ગ્લવ પેલું હા પેક વજાઈના કરી દેજો. So I think there is a opening. આ સાઈડ થી આવી જાઓ મારી બાજુથી. 2 મિનિટ હા ચેન્જ કરી લો. यस बताओ. So we have to, yes, here is the vagina. I think it will cut open. ઉપરથી જવું પડશે. જમણા હાથમાં જ ફાવશે. ઓકે પરફેક્ટ. 2 મિનિટ મને યુટ્રસના ટ્રેક્શન જોઈશે. હા કારણ કે મેનિપ્યુલેશન નથી ને એટલે. યસ પરફેક્ટ. જાઓ નીચે. યા સ્ટેડી કરો. Yeah. So we have opened the vagina. Colpotomy has been done. Please pack the vagina, Devendra bhai. સોની સીઝન લઈ લો ને. સોની સીઝન છે લાવો. Okay. So now we have luxury today of 2 energy sources. That is, one is ultrasonic energy, that is Sony season. So we will go circumferential to finish the hysterectomy. Okay. 2 મિનિટ મને એ આપો ને આપણે ટૂથ આપો. એલિસ આપી દો. Yes. Okay. Yes. So it is also a wonderful device by the COVIDian. It is cordless harmonic cordless ultrasonic energy source, and it doesn't require or it cannot પેલી બાજુ આવતા રહીએ આપી દો મને. હા મને આપો. Yes.
It doesn't have a cord, so it will
Yes,
be
madam.
very
Very,
easy to
very easy.
manipulate.
Yes,
I
definitely.
think so. That external picture should be shown. Show the external picture.
External picture
हाँ.
बताओ.
This one. So this is the, you are handling the cordless.
Yeah, madam.
Now
Yeah.
it is seen. Huh? We heard about it, but today I have the luxury to see it.
It has also no counter, so it is very cost effective compared to the Ethicon energy, other energy, ultrasonic energy source. So we have to constant see the active blade of the ultrasonic energy. That is the main thing before you know. બે મિનિટ હવે ઉપરથી આવી જઈએ. ઉપર હું આગળ પકડી લઉં છું. બતાવો. હા ચાલો. યસ. Yeah. Sorry. So one task is finished, that is of the hysterectomy. We should see that no cervical tissue is remaining behind. Yes, so there is a completion and બે મિનિટ ઉભા રહો, મૂકી આપો મને અહીંયાથી એક ગ્રાસ પર આપો. So without any spillage, I will tell my vaginal assistant to retrieve the specimen. Yes, please, Devendra bhai. લાઇટ કરો, લાઇટ આપો ત્યાં. ધીમે રહીને ખેંચજો, એકદમ ના ખેંચી કાઢતો. ઓકે. યસ, હાથ રાખજો, હાથ રાખજો. યસ, એબ્સોલ્યુટલી ગુડ. ઓકે, બસ પેક કરી દો.
Excellent, Divyesh. You
Thank you, madam.
delivered specimen very well, very nicely, and maintain the pneumoperitoneum as
Pneumo.
well.
Yes, madam.
Yes,
Thank you.
Thank you. Nice dissection. There is hardly any blood loss so far.
Yes, Charles said. So now we will go for lymphadenectomy straightforward. So here I will go from caudal to cranial, and on this side I will show from cranial to caudal. Yes. So the main thing now we'll use definitely ligature.
Divyesh, I just want to add one point that is a
Yeah.
theoretical discussion.
Yeah, madam.
Since Dr. Jayesh Amin is also there, he is a fertility specialist.
Yes,
There's
ma'am.
something called the fertility sparing therapy is also there in endometrial carcinoma. There's only one indication that is well differentiated grade 1 endometrial adenocarcinoma confirmed by DNC. And if there is no extra uterine disease, patient can be treated by hormonal therapy, and that is actually not a standard of a care. But till the patient finishes her,
But I think for that, madam, there is a new molecular classification is there that is
correct.
related to the pole and mismatch
Molecular,
repair, MMR deficient or copy
exactly.
P53. Yes, madam.
Yeah, endometrial
So
malignancy now is been divided in more of a molecular classification, which is
yeah,
the future of a therapy. But still, that option is there, and
yeah, and
patient can
molecular investigation, I guess they are very much costly and not affordable pertaining to the
correct, correct,
Indian
correct,
region, madam.
correct,
Also,
correct, correct.
the immunohistochemistry related to the sentinel node biopsy, when ultra staging we can perform, that is very much helpful related to the sentinel node biopsy, I guess. So here we can see this is the fat. I will take whole fatty tissue along with vessel, not by berry picking. So lymph node are always running parallel to the vessels. Yes. So here is the psoas muscle. Back, પાછળ અહીંયા બતાવો common iliac. Yes, definitely. Yes. So this is psoas muscle. 2 minutes, sir. So I will see for the genitofemoral nerve, not to injure it, to preserve the quality of life, not to disturb the quality of life in after surgery. So here is the genitofemoral nerve, and we can see external iliac artery. 2 મિનિટ મને નોડ પકડાય એવું આપો ને પેલું એટ્રોમેટિક આપી દો. પેલું હતું ને આપણે એટ્રોમેટિક આપી દો. સિગ્મોઇડ બરાબર છે ને સાહેબ હેડલો. So I think I will now hand over mic to the Mahesh Patel sir. Anything penal anesthesia related point, madam? Any question related to the anesthesia point of?
Dr. Mahesh, I want to ask one question. Such obese patient, you give tender bug position. So how do you maintain
અરે
the?
પેલું આપો ને યાર. એટ્રોમિક પહેલા આપી દીધું ને
Hello,
યાર.
good afternoon, madam.
Good afternoon, Dr. Mahesh.
Yes. In this
Without your help,
this much,
nothing can be done.
I do.
yeah, in
Yes.
this much Trendelenburg position,
Hmm.
in this patient, we use epidural analgesia
Okay.
Now
with
nothing.
newer analgesic like dexmedetomidine.
Hmm.
Yeah, we use, and we ultrasound with infusion pump, and we ready for
Inguinal ligament
NTG,
आएगी ना sir?
NTG infusion pump.
Okay.
हाँ.
So
बराबर ना?
at
This is
present,
તમે આને
blood
ઊંચું કરી દો
pressure
ને.
is 97/52,
પેલું આપો તમને પેરિટોનિયમ માટે.
pulse is 80,
બરાબર છે?
and
અહીંયા રહી જવું.
ETCO2 is almost 28 to 30 maintained.
What is your experience in the obese patient post-operative? What is the oxygen level? How they respond post-operatively?
In my experience, there's no much difficulty found.
हाँ हाँ ये
In obese patient,
आएगी ना डिस्टल लिमिट आएगी ना.
good analgesics at the extubation
ना
time
ना वादो नहीं.
is enough, and
यूट्रस फ्रोजन
I
माटे मोकलवा
prefer CO2 wash out
बताओ बताओ.
for post-op 30 minutes is more important in
Okay.
this laparoscopy, more than 2 hours duration. So we I put prefer
અહીંયા bleeding.
oxygen in post-op half an hour, 1 hour. So it's very beneficial in that condition.
So you give oxygen,
Yes, yes.
full oxygen.
Even 2 liter per minute.
Okay.
Even maintain oxygen level of patient. It's helpful.
During whole
As my
surgery?
experience.
During whole surgery,
No, post-op.
post-op. Okay.
Yes, post-op.
અહીંયા
After extubation in recovery area.
Okay.
Yes.
That will help in.
The CO2 wash out.
हाँ सर. So madam, we have already marked our distal limit. बताओ जो ऊपर बाजू. That is a deep circumflex iliac artery.
Yes, we can
Yes.
nicely see
Okay,
it.
so this is the only artery that is arising from the external iliac vein and crossing the uterine or external iliac artery. We will go from the this is the lateral approach to clear the lymph node from the vessels.
On the lateral side of the vessel.
Yeah, madam. Steady रहो. Perfect. Okay. So also in the paper of sentinel node biopsy and the study, the common lymph node that is involved is mainly the group of external iliac node and obturator basin. Madam.
Mostly in CA body, obturator node involvement is comparatively less.
But these are the findings of sentinel node biopsy. अंदर आओ.
It is common iliac and mostly it goes to para-aortic.
Yeah, madam. And
There's still a controversy to do a complete lymphadenectomy or you go for what we can say,
nodal dissection.
removal of enlarged nodes.
Definitely, madam. I agree.
Because in CA body, what node dissection we are doing, it's for prognosis. It will not stage up. It will not doesn't help in the changing in the prognosis of patient if you do a complete versus you do a complete systemic lymph node dissection or you go for a removal of enlarged lymph nodes.
So the therapeutic quotient of the lymphadenectomy is always debatable in endometrial carcinoma. Definitely.
Yeah.
It is always helpful for prognostic. It has prognosticate value, but
not for therapeutic.
Yeah, absolutely.
Where in a CA cervix we do a complete lymph node, that is therapeutic.
Yes.
But in CA body, so it's very controversial what to do.
Yeah.
Probably, I believe in early stage cancer, we should avoid doing a complete node dissection because it will land up in more complication because these are all good tumors and their survival is very good. So probably you will have more complication later on doing a complete node dissection. Okay, she is having 50% myometrial invasion. So we go for complete node dissection.
And I have also decided to send it for the frozen section. If one node is converted into positive, then we will go for systematic lymphadenectomy, madam. But I doubt imaging shows there is no positivity, then there will be no definite nodal involvement to the para-aortic region. Yes, this is the okay. बस 2 मिनट बस आप बेसिन उठाई लिए सीधो રાખો कैमरा છે ને હા આ માઉસ બરાબર હા 2 મિનિટ આ સાફ કરાવી દીધી લો લિગાસોર સાફ કરો so far as how many delegates are there, madam? Hello?
Hello, around 23, 18 are there attendees and
Okay,
5
ma'am.
faculties. So 83 people, 18.
It's much motivating, no problem.
18,
madam.
18.
Yeah, definitely.
But nowadays in webinars, I've seen count numbers have reduced. People have tired of webinars.
Yes, exactly.
Because recently I did know the numbers. Now the people are busy with their own work also.
Oh, yeah.
So the thing is, webinars are big. So we'll do a live demo, live what we can say workshop.
Wow.
Next we I will say we should do a live workshop. So that will be good.
No, madam, you have to arrange one workshop.
Sure.
You have to mentor GYN oncologists. But you have to guide us. Absolutely.
Definitely.
You are very senior person. And definitely
You're not audible. DVS, you're not audible. No, you're not audible. Sorry, something, your mic is having problem.
lymphoria and everything. So we can now see the bone. Hello, madam, now audible? Am I audible?
Now you are audible.
Okay. बताओ जो. So with the help of blunt and the sharp dissection, I will remove the whole basin of the extrailiac and obturator node. So one thing I want to say, madam, we have with us eminent surgical oncologist dealing with the female cancers, the Bhavna madam. So we have to work in the harmony, I think.
હા મારો આ પર્સનલ મોબાઈલ નંબર છે કઈ બી હોય તો મને ફોન કરી શકો છો ઓકે
Okay. Thank you.
ઓકે યુ વેલકમ
Hello, Pooja madam. I think we have with us Dr. Pooja Ben. પરથી આવો જાવ. અહીંયા લઈ લઈએ ને. ઓકે હા ઓકે સારું ઉભા રહેજો 2 મિનિટ મને થોડુંક એડજસ્ટ થઈ જાય પરફેક્ટ આવી જાઓ અહીંયા બતાવો પરફેક્ટ આવી રહ્યું આ સાઈડથી okay, so we'll remove the whole lymph node by the means of blunt and the sharp dissection. So it's a good basic full HD system. So no 3D is also required for this. So you can see this is obturator internus muscle. Okay, bus ઓછું કર લો શર્મા સર.
Very nice dissection. Very nice dissection.
Thank you, madam. Okay, perfect. બસ આ બાજુ આવતો રહો, લેટરલ બાજુથી. હા, બસ મૂકો ત્યાં આગળ. હા, લિમ્ફ નોડ લઈ લઈએ અહીંયા. 2 મિનિટ હું લઈ લઉં. હા, perfect. So we have to remain close with the vessel. Suppose if we are not in the good plane, then there is a bleeding from the lymphatic channel. So it will create so much problem in lymphadenectomy. બસ બસ વાંધો નહીં, એને છોડ દો ને, અહીંયાથી જ લઈ લઈએ છીએ. બતાવો આ બાજુ. So there are some either here stoic vessel which will create bleeding here. So we have to remain careful here. Okay. Okay, perfect. So I will detach all the lymphatic. जाओ नजीक जाओ थोड़ा. हाँ. All the lymphatic basin here, and it will get medialized. We will also see the obturated nerve from here, I guess. Damn it. Okay. Bas avtar. Yes. So it is a complete clearance of the external iliac node from caudal to the cranial side, and I will go now from here. We'll release the lymphatic from the external iliac vein. Sarma sir pakdi lijiye. So the here assistance role and understanding is very much important, I guess, madam. Good camera work, good coordination always needed.
And the fact is the blood pressure is also low, the veins
Yeah.
are collapsed, that also helps in dissection.
Yes, sir. We should not perform lymphadenectomy when the vein is convex. I think vein should be collapsed.
That helps in dissection.
Yeah. बस ऊपर 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 नहीं बढ़े, एने ऊंचू करी लो सर बस. Yes. So now I will release here, but there is a always the corona mortis, I guess. We have to see and see for it. So it will require a dissection here. Okay, so here is safe. I will apply the energy. Definitely it will gone. Yes. So now here we can release it. Perfect. ऊपर ही आई जी. बस हाँ हाँ. आई रही ना यहाँ थी. So our medial boundary is that is obliterated umbilical artery. So now we will release this basin from here. It will help us to go or to બસ અહીંયાથી આને રિલીઝ કરી દઈએ. Yes. Okay. So this much oozing we can avoid and go further. और लिगाश्योर साफ करा दिया, कंप्लीट खबर लो છે common iliac સુધી. હા
Divesh, it is a good dissection. You have almost hello.
હા madam.
Yeah.
Hello.
The
Yes madam.
boundaries- Yes, yes. Just for the theoretical discussion, I just want to tell that boundaries of pelvic node dissection is on the upper side. It is bifurcation of common iliac artery.
હા madam.
Lower side it is deep circumflex iliac vein, obturated now inferiorly, and obturated umbilical artery on the medial side.
Medial side, yes.
Yes, yes, yes. So this completes your dissection. The dangerous part is at the junction of external iliac and internal iliac vein, and it is easier to suture and repair external iliac vein as compared to internal iliac vein, because internal iliac vein just enters into the bone, the lower side. So you can't do anything except for the packing. I had an experience of injuring internal iliac vein once upon a time. So that is one of the most dangerous structure at this area when you are doing a pelvic node dissection. So it is
Yes,
not an
madam.
easy.
Better
Hypertension
not,
is most.
better not to injure, but
Yeah, but not to. So just at the bifurcation of external iliac and internal iliac, somebody needs to be very, very cautious. Otherwise, you might injure the
yes.
internal iliac vein. And once you finish the dissection, you actually palpate the bone. Iliac's bone is been easily palpated, so that shows you are completed your dissection.
Yes, madam. Be a minute. Obturator now. Be a minute, be a minute. So this is the obturator now.
Yes.
And below obturator you can see there is a obturator vein. You can see, madam.
Yes, 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 yes. It is easily seen. I had an experience of injuring that also once.
Yeah,
And
but
it was so much dilated because of the enlarged node, and at one moment you feel that you injured a major vessel.
yes,
But
madam.
you need to take care of that, because that vein is actually draining that nerve. I mean, that is a vasa vasorum of that particular nerve. So somebody need to be careful about that also.
So I will completely take all the lymph nodes from here. Slowly, हाँ कैमरा टच था ये पाछળ आप પકડી લો સર સર તમે આને ઊંચું કર દો હા બસ હવે તમે સ્લોલી જાઓ અંદર ઓકે પરફેક્ટ અહીંયાથી લે so it is the caudal most boundary of our lymphadenectomy. We will release it from here by taking care not to injure, as madam said, obturator. We should avoid undue tension also in this area. Yes, I agree. So this is the chain here, and okay. ઓકે બસ હવે આ સાઈડ 2 મિનિટ અને એકવાર ક્લીન કરી દઈએ ત્યાં સુધી પેલું લઈ લેવું છે આપણે સોની સીઝન લાવો ને હાર્મોનિક લાવો શું કહો છો અને આ પણ પેલું છે આઈપીએલ છે બ્લીડ ના કરે અનડ્યુ ટેન્શન થી એને કોએગ્યુલેટ કરી દો લાવો ને પેલું આપણ લિગાશ્યોર કોએગ્યુલેશન માટે
See if you Divesh.
Yeah, madam.
Yes, you are using a harmonic. That is one of the good instrument because it decreases the lymphocyte formation, which is one of the most common complication after the lymph node dissection.
It can also be done with ligature, madam. Definitely.
Yeah, it can also
It
be
will
done with the
block the.
ligation also. Yes, yes, yes. Either you have to, if you're using a unipolar or bipolar, you need to apply a lot of clips to avoid the lymphocyte formation.
Yes.
If you manipulate too much of a extrailiac vein and the other vessels, there is a chances of thromboembolic event later on also. The deep vein thrombosis or thromboembolism can occur. This is one of the most common complication of the pelvic surgery.
Yes, madam.
Yes.
આનાથી છે ને પકડાતું નથી એ ટ્રોમેટિક ગ્રાસ પર મૂકી દો ને વેનની ઉપર યસ ગાર્ડ કરો ઇન્જરી કરે છે So gauze is helpful sometimes when there is minor oozing. મૂકી રાખો અહીંયા ઉપરથી લઈ લઈએ કોમન ઇલિયક અહીંયાથી આવે છે કદાચ આવી રહ્યું Okay. Done. Yes. So here sometimes oozing is difficult when it fills the spaces. So there is a oozing of infundibulopelvic ligament.
Hello.
Hello. Okay. Perfect. Yes. અહીંયા મૂકી રાખો પરફેક્ટ આ ઊંચું લઈ લો ને સરમાં આને પકડી લો યસ આ બાજુથી બતાવો અહીંયા કોમન ઇલિયક થી યસ So we have to take care of the ureter and this is the node. And we have to. So this is the bifurcation. Everybody can see.
Yes, you're doing good dissection. Carry on.
So her ultrasonic energy blade can be useful, but I think it is safer for the arterial. And suppose you are working on the vein, then it's my opinion, not the general opinion. It is very dangerous instrument, I guess.
You should know to use which instrument where.
Yes,
That is the
key for the success of
laparoscopic surgery.
surgery. So I have taken all the common iliac node from the medial side. I will see and dissect We have to take care of vein.
Vein.
But I think remaining close to the vessel, it is very much helpful to perform a bloodless lymphatic dissection, lymphadenectomy. Okay, perfect. So here I will see for the fork of internal iliac vein. I mean, તમે છે ને આમ કરી આમ જજો હે ને પરફેક્ટ જ છે આ બી ક્લીન જ છે ઇન્સ્ટ્રુમેન્ટ બી પરફેક્ટ so we have bare the whole vessel. Wait a minute, we will not break the any lymphatic chain and bus sir, sir. So this is the tricky area and it requires sharp dissection here. This is the whole obturator basin. I'm going to take bas angle batao. Yes, so you can now see there is a this is the fork, here is the internal iliac vein. Can you see, madam?
Yes.
Yes.
So I will take this node also, because without this node the lymphadenectomy is incomplete, I guess. Okay, 2 મિનિટ હા તમારી પાસે પેલું એ છે ક્રાસ્પરી આપો ને મને શર્મા સર પેલું લેવું છે મોટું આપી ને. So it is the matter of patience, I think.
Just one suggestion. You ask your assistant to just pull the obliterated end. You will get a
Okay.
good vision.
Yeah, madam, I will.
Tell your assistant to pull the end, obliterated end near the paravesical space.
Okay, but madam, first I will finish.
You just pull it. Now
yeah,
you will
yeah.
see. Now you will get a good. You understood?
Yeah, okay, yes.
You got na? You will
Yes.
get a good. The internal iliac artery will be pulled. So you will get a good plane for dissection.
नजीक जाओ. Okay. So these are the lymphatics also from the fork area. ऊपर से release कर दिए हमें.
You release it from above, it will be much
Yeah,
easier.
okay, yeah, madam. ऊपर से जता रही. नहीं, okay, सारू. Okay. एना ऊंचू कर लो. Yes. Yeah, बताओ एंगल अगर कॉमन इलियक नोड बताओ. नहीं ये तमे बराबर था शर्मा सर. Yes. Okay, so I will take here.
That you release
Yeah.
it, so down it will be much easier.
Actually, in case of a open surgery, we get a advantage of retracting external iliac vein by vessel retractor. That I
Yeah,
think
yeah.
in laparoscopic surgery. And too much pulling without burning tissue is quite dangerous. Before you pull it out tissue, it is better to seal with a harmonic, so there won't be any small. I mean, the bleeders will be sealed there only.
Now clear it from above.
Okay, madam.
You just
Okay.
you take the
Yeah.
obliterated end, clear it from the obliterated end, you will get a good clear it, hold the obliterated end, pull.
Yeah.
Now clear it from the obliterated end. So the whole obturator node, you clear that area. Very good. Pull it laterally, so the whole tissue will come in the obturator fossa. Then you have to just go below the node. Clear it from
Okay.
the obliterated end and the internal iliac artery. Clear the whole node dissection from there. That is, we do in the open. Don't go below the obturator nerve.
Okay,
That
ma'am.
should be the dictum. Okay, fine.
आप बताओ नजीक जाओ. Bleeding નથી એટલું. Okay, no problem. Yeah. Obturator તો નથી દૂર છે.
Obturator दूर છે.
બસ perfect.
Now you just go to find out the internal iliac. Where is the internal iliac artery?
Perfect. બસ આ બતાવો બેઝિન. હા લેટરલ વોલમાં. યસ. બસ બસ લઈ લો. બ્લીડિંગ ના થાય. પરફેક્ટ. બસ. हाँ बस बस હવે લઈ લઈએ. રિલીઝ કરી દિયા ને ઉપરથી. Yeah. પકડો. So you can see this is the whole chunk. Damn it. साफ कर दीजिए हार्मोनिक. So it is a matter of patience, I think. Suppose
Put all the chunk in the obturator fossa.
yeah, madam.
Okay, then you
Trace
separate it
the-
from the internal iliac,
Yeah,
so
okay.
that thing will be totally free.
Easy, madam.
Easy. Then only the angle will remain.
Okay.
Good. Very good. Okay. Now clear it from there. So the whole thing will.
Yes. It has released. ઓકે બસ હવે ફોર્ક ઉપરથી રિલીઝ બતાવો આ બાજુ. હા 2 મિનિટ એને છે ને 2 મિનિટ આને સીધું કરી આમ કરી અને આમ. હા પરફેક્ટ. એ ફોર્ક મને દેખાવો જોઈએ નહીં તો ત્યાં આગળ બ્લીડિંગ થશે.
Don't go below the internal iliac artery.
હા હા મેડમ.
That is the nerve.
Nerve.
Okay, so
Okay.
you have cleared the angle. Now just go above the nerve.
Yes.
And the nodal tissue will come off itself.
રિપોર્ટ મોકલી દીધો દિનેશભાઈ.
ઓકે મેડમ. શું મોકલાઈ ગયો ને?
વોટ્સએપ કરીને મોકલ્યો છે બરાબર છે ને?
ઓકે.
તમારા 2-3 નંબર છે મારા પાસે છે બધામાં મોકલી દો. ઓકે.
કયો રિપોર્ટ? બસ હવે ક્લિયર થઈ ગયું. abnormality લાગે છે. બસ પકડી લો એને.
Copy this song, press any key. Charges ₹39 for 30 days.
પકડી લો ને તમે ખાલી આવી. બસ બસ હું અહીંયાથી રિલીઝ કરી દઉં. થઈ ગયું, છૂટું થઈ ગયું છે. થોડુંક જ અહીંયા બસ બતાવો, લેટરલ બાજુથી બતાવો મને. બસ કારણ કે અહીંયા.
Divesh bhai,
yes sir.
but in between I'm just here, patients. I'm having a lot of new cases, so I'm watching your surgery. I think so. Whatever all the tumor board experts and Dr. Bhavna, those who are very experienced onco surgeon, Dr. Anju Chauhan, who is she moderator and senior and mentor of your as a surgical expert, Dr. Pooja Patel and the radiation oncologist, and all the people are watching you. I think so. We must congratulate and we must say something. It's extraordinary surgery and excellent surgical performance regarding this surgery. What is the suggestion of Dr. Bhavna and Dr. Anju Chauhan that I want to hear from your side?
Dr. Jayesh, he is doing excellent job, and it really shows his patience and his hard work.
Yes.
He has done a really
So
hard
madam,
work.
now you can see this is the whole
Totally
chunk.
very nice clearance. You can see the whole chunk of
Yes.
gerator node and everything from common ilia. He has removed intact.
So it is the complete clearance from the common iliac. Batao common iliac.
It is your hard work, your effort, and to learn the subject. People don't want to go in oncology, but your hard work is really seen.
And exactly, it shows something, the experience. And I think so any surgeon, the most important part, that how many surgeries performed, it is more important. It shows that he is having a lot of experience in the GCRS, and which really speak here. And where he focused on the onco surgery, he has had a lot of hard work during this. Is all professors and everything. So I want to say some words that this all exposure is required. Until and even you are not having this much of exposure, it's very difficult to perform this type of difficult surgery and peritoneal node sampling and everything.
But sir, you give opportunity. That is the big thing, I think.
See, what I want to say something, Dr. Divyesh, it is my laparoscopy is my first passion, that I started with my journey with laparoscopy. And every time I need a one good laparoscopic surgeon, now I can say very proudly that now Wings is really having a one diamond who is going to do a very good surgery for the further on the behalf of the Wings. And we will develop together this all division, not only onco, but we are more interested in redo surgery department, especially for the gynec related also. And whenever the gynec laparoscopic onco, that means what I want to say, when it is indicated, I think so we are not interested when it is out of the box of onco, where everybody is criticized that it is not should be done by laparoscopy, it should be done by open surgery. I think so we will take care regarding the patient care. Whenever it is possible, we'll give maximum to the patient by laparoscopy or by the open surgery. The route is not important for the patient. Important part is disease-free interval in the oncology part. So how much disease-free interval? So we should not be very much stick to the route. Important part that what the pathway you are drawing, and by that pathway, how the patient is become disease-free, or maybe in disease interval-free, or where the survivability is increasing by your surgery. With association with the radiations or whatever the modes are required.
Very good comment by you, Dr. Jayesh. And the thing is, what you highlighted is that oncology is a teamwork. It is never a one-man game. It is a combination of a surgeon, a radiotherapist, medical oncologist, and everything makes an oncological outcome. So it has to be a tumor board, which you have already discussed, and it should be a teamwork. There is no man that I can do this, I can do. Even you for a laparoscopy, or we can say for open, it's always a teamwork. So that should be the concept. And with that concept, if you proceed, you will always have a good result, not only for the patient, but for you also. Whenever you are having any problem, whenever you want to take some extra major decision, if you want to do an extra major surgery, then teamwork is always best.
Most important. And also the
यहाँ
setup is
ऊपर दीजिए, ऊपर दी नीचे
that
Yes, yes.
institute should have a good setup
Yes,
for the ventilation supports and some ICU backup in some patient when it is required. That is also important.
बराबर
The
અહીંયા
surgical
थी आम जाइए
instruments are also important. Surgery is
Yes.
also important.
ऊपर थी
In the
ऊपर थी
post
जाइए
surgery, all the treatment, the tumor body is also so much important for the patients. It is not that doing a surgery and you are a very expert surgeon and then leaving the patients the post-operative follow-up. I don't think so. This is the way to go ahead for the onco-surgery.
No, so post-operative care is equally important, especially
Equally
in such type of patients. You need a good anesthetist, you need intensivist, you need people to take care post-operatively. You need whole backup. So that all
Yes.
thing is very important in oncology, and that gives a good outcome to the patient.
Exactly. That is what we are thinking. If our relative are disturbed with certain things, then what we are thinking that should be a universal standard of the treatment should be given, especially for the oncology part, because it should be not like that. It should be operated in any way, anyhow, or anywhere. There should not like word like that.
Definitely, that is the success of oncology at present.
Right.
Teamwork.
And I want to say something to all the people that when there is oncology, you should always give in the safe hands. Those who are really having experience of oncology, I think so, whatever the people are sitting. So you should not call means I am also again on the freelancing part of the oncology. It is always at good place where should be operated in a better way with the better instruments. So you should have to give the free hands to the oncologists so they can perform outrightly in their setup and in their way, and they can advise the further post-operative treatment, which is requirement for the patients. That is the carry home message that I want to deliver, because that is what we want as a patient. When we are patients or we are the victims of the oncology, then how to give a better output, that is more important, rather than we can think about commercially to operate in our operation theater and giving some harms to the patient.
You're being very modest, Dr. JS. I don't know. I think every doctor should have a mindset like you, then things will change. But that is not the scenario outside. You've been very modest and you are very good. People are very arrogant, and probably the concept is they don't want to send the patient. And
but
that is my 50%
people should
practice. My 50% practice is incomplete surgery, incomplete treatment.
Exactly.
Even Dr. Pooja is there. I think she can also comment what type of patients they are getting. But that is the way which is going on. It will take time to change the mindset of the people.
I am very upfrontly going to say something like people want to go in expert hand when when people are their relatives. Then why not? They are going to send. Patients are always a relative of other and other, so they are human beings. You need to treat. You do your expertise and rest assure the other and refer the patients when your work is completed. So when your vision is not there, you should be referring the patients. Even they are poor, then refer in the poor institute where the poor people can cater. And if the patients are having they are money, they can spend the money, then refer them in a good institute where they can spend the money. So it is not like that doing very affordable things in your clinic where the clinic is really not good and offering onco surgery. I don't think so it is right way to forward.
No, but that will take lots of, that is a different topic itself. It's a mindset of people.
I think, sir, you can also discuss the role of any IVF drug, as I have seen so many young patients with endometrial carcinoma at the age of 28 years and 30 and 35 years.
Just give me 5 minutes. I have one patient, then I will discuss everything.
Yeah. Okay, sir. You can please.
Excellent dissection, Divyesh. You've done a wonderful job by doing bilateral pelvic node dissection.
Thank you, madam.
Yeah, it's a good dissection. I mean, I can't see any blood also there. So it's almost a blood-based dissection. Thanks to your surgical skill also, and as well as both the devices you are already having.
And the motivation, madam, that I have got seeing all senior people like Anjana madam, you and everyone.
I just want to add one thing, as Anjana was just discussing, Anjana and Dr. Jayesh, with that we got a lot of incomplete surgery, and I think since last so many, like few months, I've not seen any patient who is upfront having a CA endometrium and coming to us. I think Anjana is also having the same experience. Is it so, madam? Hello.
Hello, Anjana madam. Are you there? Hello. Nothing. हाँ नीचे गया. I think. Okay. She has gone outside for tea, madam.
No issue.
Yeah,
no,
yeah.
I'm just discussing that we get a post-hysterectomy patient diagnosed with a CA endometrium. So those
Madam,
are not practicing.
but one thing I want to ask, frankly, you are a surgical oncologist, and so is it better to perform before operate per vaginal examination? Who is expert in gynae oncology? What is your frank opinion, madam?
See, when I was a general surgeon, I was not knowing much of about this everything in detail about the gynecological examination, as we have a lot of other things to do. But over the period of time, even in case of a rectal carcinoma, also those who have got a vaginal involvement, even the rectovesical infiltration of rectal cancer. So now I've been trained to everything. And the second thing is, we have been trained in urinary bladder cancers also a lot. Even I assisted many of the CA urinary bladder malignancy. Even I myself have done a lot of radical cystectomy in GCR with Dr. Hemang Bakshi sir, and that time I have assisted many of the open robotic prostatectomy also. When I was in Mumbai in Tata Memorial, I have seen robotic open prostatectomy. That time, I think 10 years back, the robotic was also not there. So I assisted many of the open prostatectomy. So pelvic area becomes very easy for surgical oncologists. This is my own experience, because if anything, any injury occurs to the bladder or even a robotic, in the open prostatectomy is also one of the most difficult operation to do, because prostate you see just below the pubic symphysis.
Yes, absolutely.
Yeah, it is not like just a uterus or bladder that it is a mobile organ and you mobilize it easily. So it's a very
just for clinical acumen, that is parametrium and everything, I guess.
See, I think the 2 to 3 years of training is sufficient for gynecologists to learn about the extra gynec things for the general also. So it's a matter of your practice and how you are practicing also.
Yes.
I think even you work in a high volume center, 6 months to 1 year experience is more than enough. You are gone to Tata. I know that it's like a factory where you worked. I worked in GCR and Tata both. So that makes you perfect at one day. Hardly doesn't make much difference, but you are a native gynecologist, so we will make some difference in that.
Absolutely,
I was discussing that thing that we get a lot of post-hysterectomy CA endometrium patients. I just want to tell those who are students as an audience, if you see endometrial thickness, patient with the post-menopausal bleeding, with endometrial wall thickness and CA125 is high. If you are even planning an open hysterectomy also or a laparoscopy, just try to either you do a biopsy before the doing surgery, or else you can use a frozen section if you are in Ahmedabad. So the diagnosis can be made on table. So pelvic or parotid lymph node dissection, whatever is to be done in a same sitting. So patient should not run here and there. And it is my own observation also. The patient, if you advise post-hysterectomy for the completion of the surgery or surgical staging, they don't come for that, and they directly go to the radiation oncologist, or sometimes they don't take a radiation also. So that makes a very controversial management of CA endometrium. And CA endometrium per se is one of the most good prognostic disease. Early CA endometrium is one of the most good prognostic disease.
आणि medially रहिलो आम लइलो तमार बाजू.
compared to CA cervix and CA ovary.
Yes, madam.
This is one of the most curable malignancies. Stage 1A or 1B CA endometrium is as good as early breast cancer.
અથડાવું છું. હા હા અને એ તો પતી જ ગયું છે. આ ખાલી આને છૂટું કરી દઈએ ને, આ ચંક બસ એ પકડી લો ને તમે. હા, કોમન ઇલિયાક થી ઉઠાઈ લઈએ. ઓકે, બસ. બસ આશા. Okay. Common iliac node. So pertaining to the port position, I am doing typically basic port placement, that is 2 5 mm port on above the anterior superior iliac spine and one middle port. And I have hold this energy source in my dominant hand, that is the middle port. Okay. Perfect. So this is the internal iliac artery. Perfect. And this is the common iliac node. Okay. So basically this is level 2 lymphadenectomy, that is gaining the node from the common iliac and up to the inferior mesenteric artery, I guess that is level 3 lymphadenectomy. પકડી લો ને સર. બસ હવે પેલી બાજુથી રિલીઝ કરી દો ઉપરની બાજુથી. So I will send this node for the frozen section to confirm its positive metastatic, because not done the sentinel, and if anything positive will go for definitely systematic complete lymphadenectomy up to the renal vein.
Divish, just want to ask you one question.
Yes, madam.
I mean, there is people say to do vaginal closure either with the endo-GI stapler.
Okay, for vaginal closure, madam, actually V-lock is a good suture, and it can also very much helpful if you do not know the skill in the closure or endoscopic suturing, and it is like boon for the beginner and V-lock, and there is no much complication noted with such as intestinal obstruction, everything with the V-lock. So it's a good suture, but I always use Vicryl, that is the cost effectiveness. I am always considering the cost effectiveness of the by treating with treatment of the patient of the cancer.
No, I'm just asking that before cutting the vagina, I mean, this closure of vaginal cuff to prevent the spillage of tumor that we do, I mean, that has been recommended in case of the CA cervix. So do you recommend to do in this CA endometrium?
Can't get your question, madam. Frankly, what are you ask? Wait a minute, madam. First, I will finish or detach this node, then I can get you your question. साफ करे दी सॉरी लो બોલો હા વાઇક્રિલ જ વાઇક્રિલ છે વીલોક આપણી પાસે વીલોક કેવું છે વીલોક છે હા તો શું એન્ડોબેગની ના પેલી એની રાઇલ્સ ટ્યુબ કટ કરી સાહેબ રાઇલ્સ ટ્યુબની જે બેગ હોય ને that we can use as endo bag if there is to retrieve the lymph node. Yes. पकड़ी लो सर शर्मा सर okay so very clearly we can see the obturator basin with complete retrieval of the આ નોડ બાકી રહેશે લેવું પડશે વાંધો નહીં પેલું પહેલા લઈ લો ને હા હા કરી ઓકે પરફેક્ટ પકડી લો સક્શન લેવું છે સક્શન લેવું હતું 2 મિનિટ okay so that is the tricky area between the retrieving the fork नहीं आँखों पकड़ो शर्मा सर आँखों नोड ત્યાં જઈ properly sorry okay okay perfect done yes I just yeah so this is the whole basin absolutely delivered without breaking or berry picking of the node okay बताइए तो पेलू नोड તમારામાં હા okay so this completes bilateral pelvic lymph node dissection hello are you is anybody there cut cut તો આવી બે આપી દો ને આવી બે આપી દો ને સાંભળ
wonderful job
થેન્ક યુ મેડમ સાંભળો પહેલા
nice dissection nice clearance
અરે પહેલા એ નાખો બરાબર એ જ બેગમાં પેલું રાઈટ સાઈડ નું લો ને બીજી બેગ પછી સેકન્ડ બેગ એ બીજી લઈ લો સાફ કરીને આપો ને સિસ્ટર લાય બેગ લાવો ને ભાઈ કટ કરીને હા કટ કર ને નીચે નીચેથી ના હા આમાંથી હા આમાંથી આવી જશે હા હા વચ્ચેનો 10 mm પોટ हेलो
hello
हाँ 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 मैडम so now retrieving the specimen in bag ઓકે, પેલા પેલા લિમ્ફ નો આ સાઈડ નો લઈ લો. ઓકે, યસ. અને ભેગો કરી નીચેથી નીચે આંગળી નાખો અને લઈ લો, પકડી લો. ઉભા રહો, ઉભા રહો, ઉભા રહો, ઉતાળો ના કરશો. યસ, પેલું કાઢી લો. હા, નીચે આંગળીથી જ આવવા દો, લઈ લો. પકડી ગઈ કોથળી, ખેંચી લો. ચલો બસ, પછી પેક કરી દેજો. ઓકે, પેક કરી દો. એ કાઢી લો, જવા દો એને ફ્રોઝનમાં. પેક કર્યું? ઓકે, લો. So these are the affordable endo bag. These are the polythene bag provided with Ryle's tube. Yes. પેલો નોડ આવે 2 મિનિટ ઉભા રહો, હું લઈ લો. બે મિનિટ, આવી ગયો આખો. યસ, ઓકે. ગોસ પીસ મૂકી દો અંદર. બીજું નાખી દઈશું જરૂર હશે તો. ઓકે, ઉભા રહો. એને પેક કરવાનું છે. યસ, યસ. ઊંચું કરો પેલું, હું નીચે નાખી દઉં. યસ, આઈ બેગ શર્મા સર જવા દો પકડીને. હા, એ પકડી લો તમે. હા, યસ. હા, ચલો આવ્યું. યસ, યસ. લઈ લો. યસ, લઈ લો. આવી ગયો, આવી ગયો. હા, લઈ લો, ખેંચી લો. યા કર્યો. યસ, પેક કરી દો. ચલો ફ્રોઝનમાં જવા દો. પેલા આવ્યો સક્શન આપી દો, ક્લીન કરી દઈએ. ફ્રોઝન વાળા આવે છે ને, લાવ. પેલી સિલિકોન આપણું સક્શન આપી દો ને. આપણું સક્શન ક્યાં છે લેપ્રોસ્કોપી નું? કિરણબેન, આ સક્શન નું કેન્યુલા ક્યાં છે આપડી? એન્ડોસ્કોપી કેન્યુલા. અરે પણ અરે આ નહીં, આપડી ક્યાં છે? આપે છે સિલિકોનની ટ્યુબ નથી, પેલા ફિટ નથી થતી. બ્લેડર ઇન્જરી નથી ના. પકડો બસ, થોડું ડિફ્લેટ કરો ને. બલ્બ કેટલો ફૂલાયેલો છે? હા, બહુ ફૂલાયેલો છે. બસ આની બેગ જાય છે ને પેલે. હેલો, સિલિકોનની ટ્યુબ નથી ભાઈ? કાલે સિલિકોનની ટ્યુબ આપી હતી ને આપને. કઈ નહીં, ખાલી આ જસ્ટ જે થોડું થોડું ઉઝિંગ છે ને એને જ લેવાનું છે, બીજું કઈ. અને ક્લિયરન્સ જોવાનું છે. પરફેક્ટ. ના ના, સલાઈની જરૂર નથી અત્યારે. હેલો ભાવના મેડમ, અંજના મેડમ. હેલો.
Yes, yes, Divesh.
Yes, madam. So this is the clearance, complete clearance of the pelvic lymph node dissection. You can see.
Very good dissection, book picture. We can say it's a photographic.
Yeah, madam. So
Ureter
this is
come-
a common iliac artery. So we have clear all the node. I think this is sub-centimeter size, but we will see. We will clear it. So this is common iliac bifurcation of the right side, external iliac artery, internal iliac artery, external iliac vein. You can see obturator internus muscle, obturator nerve. You can see obturator vein below. Yes. I
Sure,
can clear it.
Very
Obturator
good.
vein and artery. You can
Yes.
see. So we have clear it also from the obturator basin. Suction ચાલુ છે? Okay, બસ વાંધો નહીં. બસ and હા કરો ને યાર. આ નીકળી જાય છે. આ નીકળી જાય છે. આવું યાર. સિલિકોન ટ્યુબ લાવ્યો? હા લાવો ને. બસ એ લગાવો એ લાગશે. એ પેલામાં લાગશે. પેલું લગાવી દો. પેલું સેક્શન લઈ લો. સાંભળો પેલું લઈ લો. ટ્રમ્પેટ હતું ને? હા ટ્રમ્પ વાળું લગાવો. પરફેક્ટ. કોઈ કશું ચાલશે. નીચે પાઇપ ને જોજો. ઓકે ડન. સરસ. પાણી નહીં ચાલુ. પાણી ને પકડી લો સર. હા એનાટોમી બતાવો. So this is obturator vein that is arising from the internal iliac vein. Can you see, madam?
Yes, yes.
Okay, and this is uterine artery that we have already ligated. પાછળ બેક જતા રહો. Okay, and this is superior. I want to show division of the internal iliac artery. So this is obliterated umbilical artery. The first division that supplies the bladder, that is superior vesical artery. After superior vesical artery, you can see the uterine artery. You can notice this is uterine artery. Okay, so we have, this is the level 2 lymphadenectomy. That is complete clearance from the from the internal iliac artery. Yes, common iliac artery, external and internal iliac artery. So this shows the complete clearance, and we will wait for the result of frozen section. Suppose if any node comes positive, then we'll go definitely for inferior mesenteric artery and up to the renal vein. So this is the left side anatomy. Batao jo Sarma sir. This is also showing the clearance of at the level of common iliac vessels. Madam, can you see?
Yes, yes, yes.
So this is the N block lymphadenectomy of pelvis. This is uterine artery, obliterated umbilical artery. Here you can also see the external internal iliac vein tributary, that is obturator vein. Okay, so it is the complete clearance above the level of the obturator and also below the level of obturator. Now we will wait for frozen section, definitely. But we would like to show how we are preparing the field for the inferior mesenteric artery and everything. So પકડી લો શર્મા. Okay, so yeah, we will lateralize the whole sigmoid, and at the level of yes, I will push all the small bowel towards the right side, so will not come. So it is
You're going to change
arranged.
your port site?
Pardon, madam?
You're going to change your port site or not?
No, madam. Up to the mesenteric, up to the inferior mesenteric artery, we can perform with this position. You can see we will extend our cut from here, and we'll go like this, and we will separate out the sigmoid from our way up to the duodenum. The patient is obese, so we cannot trace out the inferior mesenteric artery, but inferior mesenteric is visible in thin and lean patient. I will try to show. Yeah, at the level. बताओ सर. कट करવું જ પડશે અને અગર નહીં દેખાય ફેટી છે એટલે. And for renal vein, we will change definitely our port size. Middle port will become our camera port, and we have to suspend this sigmoid, parasigmoid fat. So we'll take a stitch, and we will prepare the peritoneal flap by putting incision and separating gonadal vessels from here, and we will suspend this with straight needle of ethicon to the abdominal wall.
Okay.
Okay, but for now we will wait for the frozen section, madam. Definitely.
Sure.
So thank you all for attending and motivating me in my first live gynec onco surgery and Wings Hospital. I am also very much thankful to Anjana madam, Dr. Pooja Ben, Dr. Sanjeev Shah, that is oncopathologist, Dr. Jay Samin sir, our anesthetist, Dr. Mahesh Patel sir, and Pinal Bhai, our all Wings Hospital staff, madam. Thank you all. We will wait for the frozen section.
Yes, sure.
Divesh, it is a wonderful surgery by you.
Thank you, madam.
I just want to ask you, are you going to peritonealize again or again?
No. Hello. Down pillow. Leader છે ને એને બંધ કરી દઈએ. કાઢી લો જો. હા, ફ્રોઝન માં ગયું ફ્રોઝન. લેફ્ટ અને રાઈટ સાઈડ પેલ્વિક લિમ્ફ નોડ એ મોકલવાના છે. પેલું જે પહેલા આપ્યું તો લેબલ કર્યું બરાબર? રાઈટ ને લેફ્ટ કર્યું ને? પેલ્વિક લિમ્ફ નોડ્સ. હા. Yes, madam. So there is no need of peritonealization as far as minimal invasive surgery concerned. I am not preferring peritonealization, madam. What is your opinion, madam? Bhavna madam. Hello. Yeah, what is your opinion, madam? What?
I used to do peritonealization, but the raw surface takes fluid absorption is more in case of raw surfaces, so lymphocyte formation will be lesser, as my opinion. So I don't peritonealize. I just want to ask you one question. Do you do vaginal cuff suturing before you cut down the vagina? There's a lot of recommendation for radical.
No. It is recommended for.
CS cervix.
Yeah, CS cervix. That is because the growth is exophytic. That's why it's better to perform or to take or to make a vaginal cuff and suture and cover the growth. So, but still the results are. I doubt results are good to perform for CS cervix laparoscopically. I think. No. बस क्लीन कर दो बस अब वेट करिए आई थिंक suture I will close the vagina now.
Anjuban, do you do peritonealization or you don't do it?
One Vicryl ले लो Vicryl.
We have done stopped since last 20 years in the
10 ले लो 10. हाँ.
There's no role of doing
नीचे दिन आके दे इसो.
It causes more adhesions and probably
वीलोक हो तो वीलोक थी बंद कर दी.
peritoneectomy. So we never do
खर्चो बस. वीलोक हो तो आप ही दो वीलोक चल.
closure also.
You do closure of peritoneum?
We don't even abdominal closure also. I don't do peritoneum. I directly go for the single layer. You had stopped doing peritoneum closure since long back.
Okay. See, the
બરોબર ને
advantage of
અહીંયાથી
doing
જવાશે
pedicularization is that
પેરાયોટિક કરવું હશે તો આ રહ્યું આખું
radiation
લેયર
will be very less.
અને અપ ટુ ધ ડીઓડીનમ અહીંયા ચેન્જ કરવું પડે પોર્ટ
Post-operative radiotherapy, so the small bowel won't stuck there. If you do
નીચેથી
peritonealization, the chances of small bowel addition would be less. So it is personal choice whether to do it or not.
We have stopped doing it. We don't do it since last so many years.
Okay, 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 okay.
I don't think there is any benefit of, because whatever the addition
બ્લેડર ને ટ્રેન કરો ખેંચો ને પેલું બલ્બ ડિફ્લેટ કરો ને તો હા
is now not recommended only.
કેટલું છે તો આને થોડું પુશ કરો કારણ કે છેક નીચે સુધી ગયા છે ને વોલ્ટ કટ કર્યો નીચેથી આવા દો now I will close the vault vaginal vault with V lock it will આમ પકડીને નાખી દો ને આમ નીચેથી હા નહીં પકડાય નહીં પકડાય હા અરે છોડી દો તમે હા લઈ લો બસ પેક कर दो वजाइना अंदर आ जाओ पैक कर दियो ओके नीडल होल्डर मैरीलैंड करिए करिए आवाज
પછી પેલું હાર્મોનિક સ્ટેન્ડ વાયરલેસ હાર્મોનિક
नीडल ब्लेडर ऊंचू करो सरमस पेलो फोल्ड पकड़ी लो ने हाँ बस परफेक्ट ચાલશે યુટ્રોસ સેક્રલ આવ્યો નથી પણ ઓકે ડન બે મિનિટ ઓકે लॉक करो विलोक में लॉक લોક નહીં કરવું. સોરી, 2 મિનિટ, હું લઈ લઉં, નીડલ લઈ લઉં. Okay. So this, I am very thankful to local Ahmedabad made company, that is Glocell. You can also notice it from the instrument. And as per our Prime Minister says, you have to be vocal for local. So we are using local made Ahmedabad based instruments. Thank you, Ajay, for providing us good instruments. Sorry. कसो बस परफेक्ट. लॉक નથી થયું. ડન. પરફેક્ટ. બીજો ચાલશે એટલું. કેટલા કલાક થયા સાહેબ?
It's been 3.5 hours by now.
So with surgery, madam? So I am little bit slow surgeon, I guess.
You finish on time actually.
2:25.
I think 2:25 we started off. It is around 5:20.
Yeah.
This is your first surgery live, so the bit of apprehension is also there. So that way it is good.
Yeah, and I think there are data coming in live surgery. I guess complication definitely can happen.
Yeah. Your corticosteroid level is always high.
People are now turning out to present the videos, and live workshop will get. Yeah, in foreign side, I think live workshop will.
Yeah, few places have stopped doing the live surgery.
Yeah, definitely, madam. I agree.
Okay. The step you are doing right now is just poking your needle into the vagina. This step is very well done in robotic because it gives a wrist movement will be very good in this robotic surgery as compared to laparoscopy.
Yeah, madam.
Yeah.
Will definitely. I will ask Dr. Jayesh sir to have robo.
The new generation robotic will be very cheaper than the convention Da Vinci, which is by 25 crore.
Yeah.
And the future generation will be of a single port robots also.
ચાલશે આ લોક થઈ જશે. No problem. દેવેન્દ્રભાઈ કે આમ જ કરવું પડે મારે, નહીં તો ઉપાધિ થાય.
I think Dr. Vidyasagar is there with you.
Yes. માઇક આપો ભાઈ શર્મા સાહેબ. અરે માઇક શિફ્ટ કરો. અરે એક્સક્યુઝ મી, માઇક આપો ને શર્મા સર ને. આયરું લો, કોલર માઇક આપો. આયરું કોલર છે, બીજું કોલર માઇક લાવો. સોની સીઝન છે. ચાલશે, આનાથી કટ કરે. આપણે નહીં બહુ ફેન્સી.
મેમ
અવાજ આવે છે મેડમ શર્મા સર નું?
Yes. Dr. Sharma sir, how are you?
Yes, good afternoon, ma'am.
Yeah, good afternoon. The half of the job was done by you as well, so it was a wonderful job.
It was just a teamwork.
Yeah.
And, as Dr. Divyesh said, I would like to inform you again, or I would like to remind you one thing also, that we were just interns when you were AP at Karamsad.
I know. I remember that, and I think you were in GCS also.
And in GCS we followed you.
Yeah.
And we are trying to follow your footsteps.
No.
I'm not doing some onco surgery.
No. Thank you so much for that. Me and Dr. Jayesh Prajapati, who is a senior onco surgeon, is watching both of you. And we just talked that the half of the job is always done by assistant in laparoscopy surgery or robotic surgery.
Yeah, it is always a teamwork, ma'am, because the camera
Yeah,
person is also equally important.
Camera person is very, very important.
So is the assistant that would allow a surgeon to do a better surgery.
Basically, camera surgeon is basically eyes of a laparoscopic surgeon.
So we have a very experienced camera surgeon with us, an assistant.
Yeah,
Devendra Bhai, I think he is performing 10 to 15 surgery he is assisting per day. And Naam to- Chetan Bhavsar and Ramesh Bhai with us. Chetan Bhai has done tremendous, excellent job on the camera, madam, showing very beautifully the camera.
Dr.
Yeah.
Vidyasagar is still with the GCS or he is somewhere else?
He is professor, madam. He is senior than me.
Oh, very good. Nice to see you.
Yes. Love pani aapjo. Wash kar rahe. So before we will wait for the report, and if it comes negative, I will inform everyone, every delegates. So there is no need of para-aortic systematic lymphadenectomy.
Divesh, do you check for the bladder injury anytime, any leak test or anything?
No, madam, no. If I suppose there is a 3 or 4 surgeries, पानी करना भी चालू.
So previous, will you put a drain in this patient?
Madam, it's a clear-cut surgery. I will not recommend to put a drain. But in GCS hospital, suppose patient is more than BMI is high, more than 30, and suppose there is some.
I recommend you put a drain in this patient.
Okay,
The
okay,
first thing is she's an obese patient.
Yeah,
So
madam.
obese patient, and you have done a very good dissection. So probably there will be a chance of lymphocyte formation. So if you
So definitely we will put a drain, madam.
Yeah.
Lymphocyte formation.
Lymphocyte formation will not be prevented, but because she's
Yeah,
an
due to
obese
drain, yeah.
patient, diabetic, so mild pelvic collection, whatever, there will be a chance of high infection. So it's better to put a drain in this patient.
Okay. Is there any experience of having a large lymphocytes post-operatively? How
Yes,
do you manage abdomen in previous way?
In one patient, we have done up to the renal vein in GCS hospital. That patient develops chylous ascites, and it is, I think, a horrible dream for both of us, Sarma sir and me, ma'am. It's very difficult to tackle chylous ascites when you perform. So you have to be ready with not only with the surgery. Surgery can be performed with the skill, but you should know the basics, and you should know everything about gynec onco perspective, how to tackle all the complications and everything. Okay.
I think so. Not only surgery is important, but to
Yes,
learn
ma'am.
about complication is also important.
Definitely.
Lymphocytes which are less than 7 centimeter does not
Bantar
reach
ne
any
jo hai.
treatment, and they can be left alone. But if they are more, and if it is
Drain le lo.
causing any symptoms, then it is
Drain
better
che,
to drain them sonography guided.
हाँ ED के आप ही.
And in one of she had 10
Yes.
centimeter lymphocyte. Then we got it drained. Again, she was a case of C ovary. Then she developed
So madam,
lymphocyte.
I will wait for the report, and then
Yes,
I will put a drain, madam. Huh?
Okay, fine.
Okay.
Then we have to put
लाइट करो चालू, लाइट करो. કોબ્લર નીડલ લઈ લેજો. પેલી મોચી નીડલ છે ને એ લઈ લેજો. પોડ ક્લોઝર માટે પોડ ક્લોઝર નીડલ લઈ લેજો. ગઈ વાળી ની આની પેલી છે ને સિમ્પલ વાળી, તારી પોડ ક્લોઝર બતાય ને અજય, અહીંયા જોઈ લેજે. સીધું કરવું હોય તો કર દો. હે આ બંધ કરો.
Can we start discussing about the radiotherapy part and histology part? As Dr. Sanjeev Shah is there and Dr. Pooja is also there. Hello.
છે લઈ લો.
Hello.
Yes, madam. Good evening.
Yes, Pooja madam, now it is your turn.
Yeah, I was just wondering. Of course,
Yeah,
Divesh Bhai
yeah.
has done a wonderful job. The entire team has really worked hard.
Thanks.
And I was just wondering when will the adjuvant part be discussed?
Radiotherapists come after the surgery in case of CA endometrium. So it is now your
Correct,
turn.
correct. Correct.
So it is now
How are
your
you, Anjana
turn.
madam? Anju ma'am.
Hello.
Yes, madam. How are you?
Yes, fine. How are you, Pooja? I can't see you. Show me your face.
એના માટે madam personally આવવું પડે.
No, you can show me.
દર્શન અભિલાષી લોકોને મળવું પડે જાતે પર્સનલી આવીને તો જ દર્શન મળે.
Show me your face. Where are you at present?
Sorry, madam. I am at home only.
Hello. Pooja madam, thank you very much for your compliment.
Yes, Divesh Bhai, but it's really I have not seen laparoscopic surgery done being live, so this is my first. But it is very clean, very nice surgery.
Thank you, Pooja madam. But that's why I have kept a tumor board, madam. Not only the role of gynae oncology. So we have to consider the role of radiation oncologist and oncopathologist with us. I think Dr. Sanjeev sir, and we have also sent frozen to frozen report to the Sanjeev sir for what we have to next proceed. So Pooja ma'am, what is newer consideration after POTEC 3 or POTEC 3? Will you prefer in case of type 2 endometrium CA sandwich therapy or first chemo then radiation, madam? What is your preference?
So I always prefer going for a sandwich radiotherapy. And when we are talking about, especially about the POTEC 3 trial, we know that the POTEC has shown significant improvement in the overall survival, the failure-free survival with chemoradiotherapy versus radiotherapy alone. But having talked about this, I think since it is a workshop where we are having attendees also, let's first clarify for the role of adjuvant radiation, where it is actually. Let's start from the simpler part. So I think it's very clear for a stage 1A, grade 1, it's always an observation. For stage 1A, grade 1A to grade 2 and 3 to 1B to grade 1 and 2, it's a gray area where somebody would prefer going only for the vaginal. Other risk factors which we always take into consideration when we decide in these type of gray areas whether the external beam is required or not. Like if it is a LVSI present, if it's a low uterine segment present, if the size is more, then probably those cases where we may be tempted to go for an external beam followed by vaginal brachytherapy. Otherwise, the external beam radiation really starts from stage 1B, grade 3 onwards. So that's on the very basic part where I think the attendees would understand where is the role of adjuvant radiation. Now, having talked about the question about Divesh Bhai, whether we should go for completing the chemotherapy, entire chemotherapy, and then giving radiation, I always prefer that these advanced cases always they have equally important role for the local relapse, and that is why a sandwich radiation would be the best for these patients. What about Anjana madam and Bhavna madam's thinking on this?
Yes, Dr. Pooja, I just want to ask you one thing. What is tumor-directed radiotherapy in case of CA endometrium? Can you highlight? Yeah.
Sorry?
Tumor-directed radiotherapy.
So, see, all the basic radiation where we all know that with the 2D and the 3D, but now we are in the era where we are giving radiation image-guided. So recent, there was a trial which said that the image-guided intensity modulated radiation therapy has worked better, especially when we are talking about the bowel, reducing the bowel toxicity. So there in cases, these type of tumor-directed therapies, they work very well.
Yeah, I think, I mean, you just wanted to say it is basically a combination of external beam radiotherapy with vaginal brachytherapy.
Correct.
Because I think the dose of vaginal brachytherapy may avoid the side effect of external beam radiotherapy, and it gives an excellent overall survival and disease-free survival as well. And
So
what are the side effects?
So the role of vaginal brachytherapy is not just that because we want to reduce the side effects of the external beam radiotherapy. We know that C endometrium has a lot of chances of vaginal cuff recurrences. So that's why a vaginal brachy is very important. And that's why I said all those tumors which are 1B grade 2 below, they can easily be tackled with vaginal brachytherapy only, because there probably this treatment would be more than sufficient. But for 1B grade 3 onwards,
Hello?
yes, madam, you were asking something about the toxicities.
No. You are just finishing that sentence. So you mean to say that vaginal brachytherapy is better for the quality of life as well as for the vaginal relapses, the recurrence at the vaginal cuff. And what about the side effects? Do you encounter with this your newer modality of radiotherapy, or it is lesser than the previous radiotherapy approaches?
The newer modalities in the external beam you're talking?
Yeah, in external beam.
Yes, definitely. The latest modalities have been very helpful for decreasing the small bowel toxicity, especially because we know in the post-operative patients, it is always a big challenge that you have to balance the radiation dose to the bowels. Those especially which are very mobile and where we don't know also where they're going to be in the next day. So there, these type of advanced imaging techniques really help us to better plan and to decrease the toxicity to the bowels.
Okay. I just want to ask you one thing, Dr. Pooja, that we see a lot of post-hysterectomy C endometrium has been done by surgeon outside, and then you see it is a endometrial carcinoma. So we naturally, being an oncologist, go for the metastatic workup either in terms of MRI, abdomen, pelvis, or PET CT scan, depending upon the involvement of and myometrium. So, being a radiotherapist, what do? Do you send a patient back to oncosurgeons for the staging surgery, or you just give a radiotherapy when the patient comes to you after a simple hysterectomy without a node dissection?
No, so in C endometrium, I think it will be really a nightmare to have a patient like this who is not operated completely, because without a complete surgery, what Divesh Bhai very clearly said, that extrafacial hysterectomy plus bilateral salvagectomy plus peritoneal cytology and the pelvic lymph node dissection is the treatment of choice, or the treatment of surgery which should be approached. Having said that, any patient who is landing up with a simple hysterectomy with a diagnosis of endometrium, I think I would be more interested and more happy if my surgeon can do a complete surgery in this case, rather than just dumping to go for seeing the distant metastasis workup by PET CT and saying, no, it's fine, we can directly go for it. I would not prefer that. Any patient who refuses to do that, or if there are problems where a redo surgery would be difficult, there I would go for a metastatic workups and then decide whether the patient has to be taken for external beam radiation or not.
Dr. Pooja, I just want to ask one thing. How you decide which patient you will do vaginal brachytherapy, which patient you will keep for observation? So this is for the general public who are listening, and which patient you will go for sandwich therapy, chemo, radiation.
So, ma'am, that's what exactly I said, that when it's a stage 1A, grade 1,
no,
it's purely.
stage 1, and that is for oncologists, but probably for general gynec.
Okay. So,
CA body is divided into 3 categories. One is low risk, intermediate risk, and high risk. So I just want you to highlight what do you mean by that.
Yeah, okay. So I think any tumor which is having only less than half of the myometrium, I think that patient would be will be easier to fit for the observation category.
So it is low risk is less than 2 centimeter tumor size, well differentiated, and less than half thickness.
Correct.
Okay, so that is low risk. So that even in that category, you can preserve the ovaries if she's a young patient. By that category, you can observe. Intermediate risk comes around 2/3 thickness. So this our patient may be in the intermediate risk group because she's having 50% myometrial invasion. She's a well differentiated grade 2. She will come in the intermediate risk group. And high risk is full thickness, poorly differentiated grade 3, any other tumor more than 10 centimeters, they come in high risk group. So high risk, probably we'll treat them aggressive because CA body, it is seen that the myometrial invasion is the only prognostic risk factor which decides the nodal involvement. If it is more than 50% myometrial invasion, the node metastasis is very high. So we have to treat them with a aggressive chemoradiation. So this
Absolutely.
is my, what is, you want to add something?
Yes, ma'am. And in the high risk, even other two histologies, we should be always taken care of, the serous and the clear, because these are all the tumors which behave very aggressively as compared to the other counterparts.
Putting the high risk total, even if it is a less than 2 centimeter, a half thickness, if it is a clear cell, it could be, so it directly becomes a high risk category. And you
Exactly,
have to go
exactly.
for complete staging, and you have to go for complete node dissection. If it is
I,
half
Absolutely.
thickness, there is no road.
I want to
Dinesh,
ask
you
one
want to add
question to
something?
Pooja ma'am. Hello. Is there any role of time interval after completion of surgery to have a radiotherapy after completing surgery, Pooja ma'am?
So we are talking about those.
Post-operative, after surgery, is it preferable to have a radiation within 6 weeks of after 6 weeks of surgery, or time interval matters or not? That I want to ask you.
So I don't remember any guidelines specifically for the endometrial which talk about this timeline. But
Okay.
yes, but when I said that when we have to add the chemotherapy, I would prefer to have the radiation the sandwich category.
Yeah. Okay. And have you any experience about type 2 endometrium that is high grade with systematic full lymphadenectomy and radiation? Any related complications to these patients particularly?
So Divesh bhai, that is what we and Bhavna Ben was trying to emphasize in this era where we are trying to do majority of the cases the image guided intensity model radiation therapy. The chances of complications are very very less. In fact, there are I know Bhavna Man would agree for this that there were patients where even she was a little bit reluctant or worried that whether that patient can be complete the radiation therapy without any side effects. But those patients also many such type of obese patients and diabetes and other high risk comorbidities patients also have completed radiation, especially when they're on these advanced treatment modalities. But I'm really not sure for the 2D or the simple 3D plan. There you can really add up in a lot of toxicities, lot of bowel injuries.
And what are the hindrance or what are the problems you face in the obese patients? 80, 90 kg. These are the type 1 CA body. They are very obese. So radiation, any problem you have? Making a feet or something like that?
Making a?
And marking the field and everything, they are obese.
No, not in that way, madam. But usually obese patients, what we have seen is they fold areas. And if they have diabetes also, then these reactions could be quite high. Obese patients, as such, if we are able to maintain the bladder protocol and if we are able with the image guided, we are very sure. I think the complications are not that high what we anticipate.
Okay, fine.
Now the report is ready. So I will ask Sanjeev sir to please announce the frozen report. I have already been informed that both bilateral pelvic lymph node, they are free and they are reactive. So there is no need of systematic lymphadenectomy. Para-aortic lymphadenectomy. So in this perspective, I guess there is a role of sentinel lymph node biopsy, mainly in low grade carcinoma and intermediate risk factor. So in high risk factors with endometrium CA, we have definitely to perform the para-aortic lymphadenectomy up to the renal vein, madam. Sanjeev sir, are you there? Hello.
We have received both right and left pelvic lymph nodes, and almost 10 nodes are there from the both sides. Right side largest lymph node is 2.5 centimeter, and left side is 4.5 centimeter. We have done serial sectionings of the all nodes, and grossly on smears and sections there is no metastasis, macro or micro metastasis. Isolated tumor size is difficult to comment on the frozen sections. Will that decide on the paraffin section? So from my side, all bilateral pelvic nodes, there is no metastasis.
So we'll definitely wait for the final report. Definitely. Yeah. Thank you very much, sir.
Thank
Sir,
you.
can you please
Dinesh.
elaborate molecular classification, newer molecular classification about endometrium CA to treat low grade or conservative management of the patients with comorbidity. Can you please elaborate, sir?
See, the
If you
molecular classification is available, but in routine practice, very few people are practicing. Whenever on morphology, it's grade 2 or grade 3 tumors, we have to do combinations of morphology with immunohistochemistry. In immunohistochemistry, we do P53, MSI, and then molecular. We decide, yeah, we divide tumors based on
Copy
MSI.
count low and copy count high.
Yeah, that is very broad, means very extensive classification. Copy number high and copy number low tumors. Then we have to decide whether is a Paul mutated or Paul not mutated, and MSI high or MSI low. So the extensive classification is there, and in between I have sent detailed articles to majority of you by WhatsApp.
Probably this molecular classification is not done in Gujarat. It has been started at only one level. I think so in Bombay they are doing it. And the molecular classification has come into existence because they have found out that many high risk CA body patients, even being high risk, they do very well. And certain people high risk, they are not doing well. So depending upon the molecular classification, they again subgroup. So if they are if they are P3 mutated, if there's a Paul mutation is there, then it is a good prognostic tumor.
Yeah.
So that they define for adjuvant therapy, but still it is in very initial stage, and it's something like learning stage.
Yeah. So, madam, apart from adjuvant therapy, it's very important if you're able to pick up these serous tumors on endometrial biopsy, because sometimes what happens is a mixed tumor. Majority area will be showing endometrial like morphology, and particularly if it is a polypoid tumor, in some areas they may have serous component. And if you pick up the serous component, automatically your treatment plan will change. There is high risk of metastasis to regional lymph nodes. If it is a pure endometrial grade 1, grade 2, you may not do extensive lymph node dissection. So that molecular classification is more important therapeutically on endometrial biopsy or DNC material.
So that is going to be the norm of CA body management in future.
Yeah.
At present, the thing is further management will develop on the molecular classification only. And the thing is molecular classification can be easily done by IHC. Only for Paul mutation, you have to have a different panel, and it's a different technique. So that is the cost effective factor. Whether but P53 and low copy number low and high, that can be done in routine IHC. That is correct, na, Sanjeev?
No, copy number we have to do genetic testing. We cannot do by immunohistochemistry. MSI, P53 we can do.
MSI and P53 can be done by IHC. And for that pole mutation, you have to go for different technique. It is itself is costly.
Molecular testing.
So Sanjeev sir, can I ask? So, hello.
Hello.
Yes, you carry on.
No, mine's finished.
Okay. Sanjeev sir, can I ask you one question? Hello.
Yeah, tell me.
Sanjay sir, what is the role of frozen section in surgical staging of low risk endometrial carcinoma? As many of the times, if you do a frozen section for diagnosis, and it will be upgraded in stages on the final histopathology. So, what is your recommendation for intraoperative frozen section for low grade, low risk endometrial malignancies?
Frozen section is not actually only study of the slides. The entire specimen grossing is very important when you stage the endometrial adenocarcinoma body type. And on the section, you have to see where is actually tumor location. If it's in fundic region, cervical involvement is out, and that cervical involvement you will able to assess at least on CT or MR good. When if it is fundus or upper body involvement, we have to see whether there is involvement of myometrium or not. Grossly myometrium infiltration, we can check definitely whether it's more than 50% or less than 50%, except when adenomyosis. In those cases, it becomes a little bit difficult. So in the frozen, grossing is very important rather than seeing only slide. After doing crossing, we can take a sections from the most area with the maximum depth of infiltration, and that we should examine under a microscope. So crossing is important first, and then taking sections from the area where there is a maximum depth of infiltration for upper body tumor. Lower body, we can take cervical bits to see whether the cervical stroma infiltration is there or not.
So you mean to say the frozen section has got higher agreement with the myometrial invasion?
Yeah, definitely. If we do proper crossing is important because the depth is not uniform everywhere in the
I think the final decision it is on the radiological imaging also. What is your MRI finding? What is the frozen section finding? What is the abnormality you see in the nodes? And basically, if everything is in concurrent, then I think so you can take a decision to take a call whether to go for a, upper abdomen node dissection, para-aortic node dissection or not. So it will be combination of both radiological and the frozen section and histopathology. Everything. If your oncohistopathologists, they are very trained in managing this patient. So I think very less chance to get, unless you're treating a very high risk type of patient then. But usually I think so the reports are concurrent with the histopathological frozen reports. What do you say, Dr. Sanjeev?
Yeah, majority is concurrent. Except in care of involvement of adenomasis foci, many people consider that as a invasive focus, but actually that is not area of infiltration. If adenomas is there, we have to consider depth of infiltration from area of focus of adenomasis, not from endomyojunction. That we have to take care. If you take care of that thing, then histopathology reports are concurrent with the CT or MR report.
Okay. One thing to Dr. Pooja, if the para-aortic is positive, you will radiate this area or not radiate the area? Dr. Pooja is there?
Yes, madam. If the para-aortics are positive, then definitely we have to take in the radiation portal.
Okay. And what are the complications and what are the problems you get?
I think para-aortic, if positive, then it is definitely stage 3. Then the prognosis is definitely poor. Agree? Correct or not, Pooja madam?
Yes, correct. But the madam, to your question, when we are treating the para-aortic, the most common complication is that we get a lot of complaints of nausea, vomiting, because that is a GI toxicity is quite high when we are radiating the para-aortic, which routinely in the pelvis is not a problem for us.
So if a pelvic node is positive, para-aortic negative, then you will radiate or not?
No, then we will not radiate because we know
that is the importance of doing a para-aortic node dissection. So if it is negative, then you don't radiate, so you reduce the morbidity of the patient.
True.
So now, thank you. I'm like now I will yes, Girish sir. I request Girish sir to conclude the webinar, sir. Girish sir, please.
Okay.
He was throughout here. Huh?
Yeah.
He's enjoying the surgery.
Yeah, thank you.
As a fetal medicine consultant, I would love to present a vote of thanks on behalf of the team members of our WINGS hospital. WINGS-SURGICON was a great event, and the way Dr. Divyesh has carried out the whole retroperitoneal dissection. After a long time, I have seen such a very good surgery, and approximately 500 people, they watched your video, and we would love to see your surgery again and again. Once again, I see that our deep infiltrating surgeries, deep infiltrating endometriomas and carcinomatous surgeries, that part was lacking. And after Divyesh has taken over, I feel such surgeries will take over here in our WINGS hospital and patients will be benefited. Thank you, Divyesh, once again from my bottom of the heart and WINGS hospital to conduct such a very good WINGS-SURGICON.
So I would like also thankful to take part Dr. Anjana madam, Dr. Bhavna madam, Dr. Pooja madam, Dr. Sanjeev sir. Thank you very much. And I would like also thankful to our audiovisual team, that is Majestic Audiovisual, Dhyanesh bhai, our associate Covidian company mainly today for the stores. Lotus for providing us support in the form of visible pods and everything. So I would like to thank everybody from the Wings staff, Wings nursing staff, and everyone, managing staff, and everyone. Thank you very much, sir.
Thank you, Divas.
Thank you, madam.
Really enjoyed. Thank you.
Thank you, madam.
Thank
Thank you.
Thank you, Divesh, for the invitation and such a good experience.
Thank you, madam. You are welcome.
Thank you, Devesh bhai.
Thank you.
Thank you to Jayesh Amin sir also.